Today's agenda is focused on the intersection between cancer and occupational health, and we have a tremendous lineup of speakers for you today. I know I'm very excited to hear from everybody, so we know you'll enjoy. If we can start by all of you taking a moment to introduce yourself in the chat. If you would put your name, your pronouns, and your organization in the chat, that would be wonderful, so we all know who our colleagues are here in the same space today. And then before we get to our really fantastic speakers, I want to share a few updates from the Iowa Cancer Consortium. First, a little housekeeping. If you registered for CEUs, you should have gotten instructions via email, but your email wouldn't have included this important code that you see on this slide. Also, Bree, little side note here, Bree is going to drop a link in the chat with these instructions. So don't worry if we move too fast through this slide, or if you can't find your email, you'll be getting the instructions in the chat as well. You have a little bit of time to complete the evaluation part, but please note that step 1 here needs to be completed within 24 hours in order for you to get your CEUs. So be sure to text that code to the number here on the screen and in the slide that you'll get in the chat as well within 24 hours, and then you'll have a little bit more time to complete the evaluation after that. If you didn't get registered for CEUs, don't worry, anyone can go through this process. So if you still need to get them, please go ahead and engage with this process. Again, do that texting step, that first texting step within the next 24 hours in order to get your CEUs. And as always, you can reach out to us at staff@canceriowa.org if you need assistance. We have a couple new team members who have joined us since the last time this network was together. Before I introduce them, I'm going to put our staff on the spot and ask them all to raise their hands so that you can see our staff folks who are on the meeting today. This is the team that's bringing you the spring meeting, and of course is always happy to connect you to partners and opportunities within cancer control. And we have a special welcome today to Megan Hartwig, who is our new Rural Community Outreach Coordinator, working with our rural work group, and Bree McNulty, who is with us for a couple years through the CDC Public Health Associate Program. So happy to have them both on our team. And if you haven't met them already, I know you'll enjoy doing that when you get a chance to. Right. Another group that I did not warn, and I am also going to put this group on the spot. Our staff can lower their hands if you would. And if you're a board member and on and able to, if you would raise your hand here too, so that our participants can see who you are and see who's here. We have a wonderful board of directors. The consortium is a member-led organization, and our board of directors are elected from our membership, and they do an amazing job helping to steer the direction of our organization. If this is something that is of interest to those of you who are on the meeting today and are members of the consortium, we have an opportunity going on right now where you can nominate yourself or others to run for our board of directors. Again, it is an election, but now is the time to speak up and say, I'm interested in exploring that and maybe being on the ballot this year. We'll be electing a president, vice president, and 4 at-large board seats with this next election for fiscal year 25. Nominations are due by 5 p.m. on May 13th, so you have a little time, and I would be so happy to talk to you about what that means to serve on the board of directors. Bree, would you drop my email in the chat? And if you are interested, please reach out. We can have a conversation. Want to share with you a few grant opportunities. Hopefully you all know about these. They've been open for a little while, and hopefully you've gotten some good communication about them, but we want to share them here too to make sure everybody is aware. The first opportunity that you should know about, and this one has an important deadline associated with it, is our fiscal year 25 Iowa Cancer Plan Implementation Grant opportunity. So this is an invitation for proposals for projects that support priorities, strategies, action steps that are within the Iowa Cancer Plan. Applications are not due until later in May, but really important note, we do require a letter of intent, and those are due tomorrow, April 26th. So I'll tell you a little bit about how easy that is here in a second. But first, let me tell you that these grants are up to $25,000 per year. And this year, the board is giving priority to proposed projects that advance health equity across the cancer continuum, enhance mental health support for cancer survivors and caregivers, address the cancer types and sites that are especially high and/or rising in Iowa, expand successful local projects statewide, and projects that formalize lasting and broad change in cancer control through policy and systems change. So as I mentioned, letters of intent are due tomorrow. Great news. This is actually a really easy step, and it is not scored, though it is required. So this can be as simple as sending us an email and saying, I intend to apply for an Iowa Cancer Plan implementation grant. I plan to focus on, and you could identify what your project is about or the area of the cancer plan that you'll be focusing on, and that satisfies that requirement. Again, they're not scored, even though they are required. These are simply to help us know how many grant reviewers we need to find. So please reach out if you have questions. They are due to, letters of intent are due tomorrow, and then you'll have about a month to complete your application. We also have a survivorship grant opportunity open right now. The Department of Health and Human Services are great partners there, and the consortium have received funding from CDC to increase support networks that offer group psychosocial support and help survivors express and manage disease-related emotions, increase social support, enhance relationships with family and physicians, and improve symptom control. These are will be awarded later this fiscal year as well. We have a total of $25,000 to award, so that will affect how many we award, but we're looking for great applications now. Applications are due April 29th, and I know that Bree is putting all of the links you need in the chat, but if you have questions, again, reach out to us. We're happy to talk to you about that. And then our ever popular Sun Safety Community Project. This is such a fun one. I love this picture of this little person who is clearly passionate about sun safety and using sunscreen. You can request up to 3 gallons of sunscreen in pumps like the one shown here for community activities in the summer, for pools, for daycares, for schools, any place that could use some bulk sunscreen to improve the sun safety of Iowans across the summer. You can apply for that. It's a pretty simple application process, and it's just kind of a fun thing. Those applications are also due Monday, April 29th, and the information is available on our website. And we want to give a big shout out to the University of Iowa Holden Comprehensive Cancer Center, who is pitching in this year and making sure that we can cover the demand. We have high demand for this, and the cost of sunscreen is going up. So thanks to the Holden Comprehensive Cancer Center for helping us cover these costs and making sure we can get sunscreen to everybody. And I love sharing this news. I'm sure you've all seen it, but I don't think we can share it enough. I hope your calendars are marked for October 15th for the Iowa Cancer Summit. Our keynote speaker, we're so excited to welcome Dr. Kimron Rathmel, who is the director of the National Cancer Institute. She has a history with Iowa, and we've been having wonderful conversations with her. She's so excited to meet partners, hear from Iowans, talk about what cancer control looks like here in Iowa. It is going to be an amazing and wonderful event to have her there. So please mark your calendars. Registration is coming soon. There will be a virtual option. And then if you're interested in participating as a speaker or know of a speaker who would be really great for the network to hear from, we have a call for speakers that's open. It's really easy to fill out the form. And the call for speakers is open until July 31st. So you have some time to put some thought to that. But again, it's going to be a really great event, welcoming Dr. Rathmel and getting the network together. We'll have more information about registration, exhibiting, sponsorship coming up this summer. Isn't it nice to talk about summer? Makes me feel good that that's right around the corner. Also want to share with you that we have a new resource available on the Iowa Cancer Consortium website. There's a nice picture of it here and a link, which I'm sure Bree will drop in the chat for you. This is a partnership between the partners you see listed here, convened by the University of Iowa Holden Comprehensive Cancer Center, and partners in the consortium's research and clinical trials work group to make sure that there is one place in the state where there's a comprehensive list of where patients, caregivers, providers can go to find cancer clinical trials. On the page, there are also lots of resources about clinical trials. So it's not just a list of places to look for cancer clinical trials, but it's also got great information about clinical trials. If you're an organization that has an interest in helping to promote clinical trials or is engaged in clinical trials, we would love if you would link to this page from your website. We also have a downloadable message set that talks about the site and the importance of cancer clinical trials here in our state that you can use on your organizational or personal social media as well. They're already written and easy to use, so we hope you'll check out that page as well. And then this is just a reminder that between the spring meeting today and the summit in October, there are so many opportunities to connect with your fellow cancer control practitioners. We have numerous work groups and committees that you can participate in focused around topics. We offer new member orientations, and Bree's going to drop a link in the chat where you can find all of our upcoming events. So we hope you'll check those out. Right. And now I would like to welcome Georgia Hodge, who is the secretary of our board of directors and also serves as our Blackhawk County Community Outreach Coordinator. I'd like to welcome Georgia to introduce our first speakers. Welcome, Georgia.
Thank you, Kelly, and I want to thank everyone for attending our spring meeting. And I just want to, we are kicking off today's meeting with an inspirational example of what employers can do to keep their employees healthy. I have the pleasure of introducing Erin Baird and Tabitha Leidholt from Wells Enterprise Incorporated in Lamars, Iowa. Erin is a manager of enterprise benefits, and Tabitha is a manager of health wellness. We will have time, after they speak, you'll have time to ask questions, and you can put the questions in your chat as you're going through, so in case you forget. And after they present, we'll have time to answer those questions. And so now, I'd like to welcome Erin and Tabitha. Thank you both for coming.
Good morning, everyone, and thank you for inviting Wells to participate in your meeting today. Tabitha and I are very excited to be able to share a little bit about Wells and our benefits and health and wellness programs that we offer employees. That also includes our on-site occupational services. And can everyone see my screen? Put it in presenter mode here. There we go. All right, so a little bit about Wells and kind of our history. Wells was started in 1913 when Fred Wells purchased a horse, a delivery wagon, a few cans and jars, and the goodwill of the business from a dairy farmer in Lamars, Iowa, all for $250. Wells has built a legacy on sharing the joy of ice cream. And from that, we've grown to be the largest privately held ice cream and frozen treat manufacturer in the United States. We're continuously adapting to a changing industry and times while staying true to what our founders started in 1913. Wells produces more than 200 million gallons of ice cream per year and distributes products in all 50 states. What started as a Blue Bunny ice cream has grown into include multiple brands and licensed products. We're growing with a focus on our next 100 years behind our leading consumer brands of Blue Bunny, Halo Top, Bomb Pop, and Blue Ribbon Classics. With a relentless focus on food safety, quality, and innovation, our purpose is to sweeten life and ultimately create a world where everyone can feel joy every day. We are proud to be an independent operating company of the Ferrero Group, one of the global leaders in sweet packaged foods. At Wells, we employ nearly 4,000 ice cream aficionados across the country. Our population is very diverse in many ways. The ages of our employees range from 20 years up to 83 years, with an average age of 47. The female population makes up about 33% of our population, while males make up about 67% of our population. And the primary languages spoken amongst our employees are English and Spanish. However, we do have employees that speak Amharic, Oromo, and French. We're headquartered in Le Mars, Iowa. We have 2 manufacturing plants in Le Mars, a manufacturing plant in Dunkirk, New York, another manufacturing plant in Henderson, Nevada, and we have offices in Sioux City, Iowa, Chicago, Illinois, and Bentonville, Arkansas. We also employ around 240 remote employees that are scattered across the United States. Our health and wellness goal is to keep our employees and their dependents well through prevention and early detection. We take a holistic approach with our benefits, health and wellness programs, focusing on the whole person. We offer 3 medical plans with pharmacy benefits, and our medical plan members have access to different types of programs, one being a diabetes management program for type 1 and type 2 diabetics. And we also have a pharmacy benefit that includes a $0 copay for specialty medications, and those programs are at no additional cost to our members. Our dental and vision plans also include additional screenings and exams for members that have cancer or other critical illnesses such as diabetes. And we support employees through our sick leave policy and a PTO donation policy. Employees can use their sick leave for wellness exams, doctor's appointments, days that they may be ill, and they can also use their sick leave to take care of family members that may be ill or have doctor's appointments. Our PTO donation policy supports employees that are when a need or are in crisis. So other employees can donate their PTO to that employee that might be facing that challenge. We also offer different types of supplemental insurance benefits such as critical illness, hospital indemnity, and accident plans. We have an employee assistance program to support the mental health of our employees and their household members. And then in 2021, we had a grand opening for our on-site health center. And then we also offer occupational nursing services and wellness initiatives. And Tabitha is going to talk about these last 3 bullet points here in just a moment. Our medical plans do include preventative wellness exams. Those are covered at 100%, so the employee does not have to, or member does not have to pay anything for those preventative exams. This slide just shows you a little bit about the participation rates for our wellness exams and preventative screenings. So the purple bar represents the benchmark, and the blue line on the graph represents participation in 2023. So you can see wellness exams and most other preventative screenings rose in 2023. We did see a decline in our screenings because of the COVID pandemic. So we are seeing those to come back up. Colorectal cancer screenings and cervical cancer screenings are above the benchmark, and our wellness exams and breast cancer screenings are well below the benchmark for 2023. However, through education, communication, and partnerships with our vendors, our on-site clinic staff, our on-site nurses, we do expect to see participation rise again over the coming years. With that, I will turn it over to Tabitha, and she's going to share information about our on-site health center, our occupational nursing program, wellness initiatives, and how providers can partner and support employers. Tabitha?
Well, thank you again for inviting us. We're very pleased to be able to present the breadth of our programming is based on an employer who really values their employees. They want to make ice cream. That's great. But we can't make our ice cream without our employees. And so everything we do is to proactively keep those employees well. And also, if they do get ill, to support them and their families during that time frame, and to really be partnering with them. Part of that partnership is through our plant nursing teams. So as Erin mentioned, we have a plant in Henderson, Nevada. I have a full-time nurse there. We have a plant in Dunkirk, New York, a full-time nurse there, and 2 plants in Lamar's. One has a full-time nurse and the other one has nursing 24 hours a day, 7 days a week. Really wanting to focus on the whole person and bringing the services to the employee. We don't want them to have to take time off of work if they don't need to, or miss out on some financial opportunities for seeing their providers. So again, if we can get to them where they are, we can also be proactive and help to identify and support them. Our plant nurses are managed by outside partners. We have Mercy One out of Sioux City, who helps us with our nurses in Lamar's. And then we have Everside Marathon Health, who has our nurses in Dunkirk and Henderson. And the reason we do this is we want our employees to know that their protected health information is very sacred, that Wells does not have access to it, except for in cases where it's work comp, where, of course, we would be allotted that access. Really one-stop shop for the nurses. We say, if anything's going on, go see the nurse and they'll get you to where you need to be. We want to have them as that partner, that relationship with the employees for anything they might need. So nurses will provide first aid, worksite illness or injury. Nurses try to be proactive and help identify safety concerns, preventing any issues from happening. But if an employee comes and says, I'm starting to have pain, the nurses are going to partner with them through exercise, through non-pharmacological interventions, etc. Really want to catch things early, treat, and prevent. And then, of course, if there is a workplace injury, the nurses will partner with that employee the entire time through that case to provide that comfort, reassurance, that support, and do anything we can to help them. As I mentioned, nurses will also see them for personal illnesses. So anything, any topic, I can't sleep, my daughter's having an issue, etc., anything, you can see the nurse. Education, we provide some monthly topics. We'll go into that in a little bit more detail later. Drug and alcohol testing. As I mentioned, if the nurses are going to be our one-stop shop, they also need some resources. So we have 211 and our Employee Assistance Program, EAP, that the nurses refer our employees to for a variety of issues, especially mental health resources. Nurses also provide COVID and flu testing on-site, flu vaccines. They'll test blood sugars, blood pressure, anything, that they can do to try and help you be well at work. And of course, we refer to our health center and other primary care providers as needed. The health center, very exciting. So what we're looking at here is on the left is the picture of the health center. What we did was we carved out a corner of the corporate office. So there's a separate entrance there so that anybody can get to the health center, including spouses and dependents who wouldn't otherwise have the security badge as a Wells employee. So that door is automatically unlocked during business hours for the clinic. The clinic has 4 exam rooms. You can see the one hallway there on the top with 2 of the exam rooms. And then the next picture is actual exam room. Just like you'd expect in any clinic you go to, we have all of the same equipment, all of the same information there. And then the bottom picture is just a little picture of our lab. We do some of the point of care testing there. Anything else, blood draws, etc., that require more, we'll send those out to a reference lab. We also have a small pharmacy stocked with some of the most commonly used meds, a lot of diabetic meds or antibiotics, things like that. We have a multi-purpose room in the health center that we use for educational topics. We also bring in a massage therapist once a month. She uses that room for employee massages. And then there's a hearing booth for hearing testing as well. So with the health center, we love to see people at the corporate campus in Lamar's, but we have a nationwide presence. So our providers are licensed in our main states, New York, Nevada, especially, as well as South Dakota, Iowa, Nebraska, Illinois. All Wells employees, whether they're on a health plan or not, can be seen at the health center. As far as spouses and dependents, they need to be on a health plan to use the health center. We try to keep the costs down for our employees. So if you're on one of our PPO plans, it's free. However, if you're on our qualified high deductible plan or you don't have a Wells insurance, it's $45. And it's an IRS rule why we had to do that. And then the pharmacy I mentioned, $4. $4 per script that we send out. Now, if we don't have it on site, the provider will just send it off to a regular pharmacy as per usual. So services we provide, right now we have Ann Luke, a nurse practitioner, 4 days a week. And then we have another nurse practitioner on Fridays. Ann has 23 years of experience. She has a great way of knowing and understanding family practice. She enjoys taking care of patients of all ages. She's originally from California, just moved to Iowa as her daughter is graduating from school as a medical resident in Sioux City. So again, like I said, we're gonna see our employees for whether it's a work-related injury, illness, or a personal one. Really focusing on we can be your primary care or we can partner with your primary care. We want to be able to see you when you're well. We want to be able to see you when you're sick. So we do a lot of annual wellness and sports physicals, proactive wellness checks. But when you're sick and you can't get into your regular doctor or the health center is your primary care, same day appointments are always welcomed. We run a lot like an urgent care some days, especially during the peak seasons. Again, focusing on that proactive, we offer healthy lifestyle coaching. They have a couple different programs, Healthy Weight for Me and Tobacco Cessation, that are amazing programs, well structured, and you can partner the employee and the providers together to walk through those journeys, because we all know weight and tobacco are two hard habits. And so all the support you can get is great. Offering immunization, labs, pharmacy, as I mentioned. And then we have all those employees in other states. So again, virtual telehealth care, really anything, if they're ill and we can handle it through telehealth, we will. But if not, then we can make a referral to a local provider. Focusing on that lifestyle coaching and anything we can do to reach out. Our nurses in Henderson and Dunkirk are also doing COVID testing. So, if an employee has COVID with some severe symptoms, we'll set up a telehealth, or if you're influenza A or B positive, set up a telehealth, and our providers can write scripts in those states as well. So really an exciting opportunity that we offer to our employees. The health center is open 50 hours a week, starting at 7 a.m. and going till 5:30 p.m. Part of that is access for our employees, as well as the different time zones for Dunkirk and Henderson. So next. All right. So wellness, of course, we know wellness programs took a little bit of a backseat during COVID. We were kind of in crisis mode, but now we're back with our wellness programming, getting in front of our employees with education. You'll notice that a lot of our education, colorectal cancer, cervical cancer, the importance of annual exams, skin care in the summer, tobacco cessation, a lot of those programs are relevant to the great work that you guys do as well. We do have a strong focus on mental health as well. May being Mental Health Month, we'll have a big push of education this next month as well. We're really revitalizing our wellness initiatives, looking at ways to identify what the employees need and want, and then get them involved in delivering that. Some exciting things we do, we have blood drives, but this on-site mammogram, we partner through Avera. They bring the mammograms to us, and then our health center also does well woman checks on the same day. So employees who are able to schedule a mammogram and physical on the same day, get it done and get that preventative care. Again, it's all about that access, bringing that service to our employees where they are so that it's easier for them to access it and use it. Some other things across our enterprise, anytime there's an event or an education and they're giving away prizes, they're really great about looking at wellness. Some ideas we've had in the past were like kayaks, bikes, massage chairs, things like that. Really keeping that wellness and that holistic health of our employees present in a lot of the events we do. So very robust programming that Wells offers, as well as outside the box. We're willing to entertain any idea, any partnership. And so really that's where you guys come in. For all employers, Erin, do you want to go to the next slide? Thank you. So for all employers in your area throughout Iowa is really, I looked at your chats and I looked at everybody's where you're working and what you're doing. And what I see is a lot of experts on this call. And so that's where we would reach out and say, bring some information, bring your expertise to the employer, meet them where they are at their location instead of coming to where you are. All of those monthly health topics are given to me. I'm not the subject matter expert. I take the information that's given to me and I distribute it in multiple ways to our employees. Some of those ways include like our break room TVs that are kind of a slideshow. So those are like just like a slide here, a JPEG that we can just circle through those. Sometimes we hang up educational flyers. Sometimes we have put some different things on our website, our internal website, and other topics that are very important and very timely. We might email out an article. So again, really asking for your guys' help to be that subject matter expert and sharing educational opportunities. Even if you can go to an employer and sit in the break room for a while, have some of your information present and really reach out to those employees where they are. So being willing to go on site to partner with those employees. And again, that just builds that relationship and it spreads your word and the great work that you're doing to more people, and ultimately helps us keep our employees well, early detection, and keeping them making ice cream. So thank you very much. That was a lot. I talk fast. I'm a little passionate about it. But thank you very much for your time. I would love it if anybody has questions. Oh, asking for a friend. How do you get free ice cream? This is the interesting one. If you notice my title, it was health and wellness. My job is health and wellness in an ice cream factory. And yes, when you work at Wells, when you are at work, you get free ice cream. Every break room has a bunker full of ice cream. So my job is health and wellness, but we give away free ice cream to our employees. Absolutely.
Looks like we do have a question too, Tabitha, in regards to the health center and prescriptions. So the question is, does everyone pay $4 for each prescription, or can they use prescription insurance if they would pay less?
So we don't bill through their insurance from the health center. I don't think, based on our coverage, and Erin, you can specify too, I don't think you're going to get it for any less than $4 through any insurance. But if they wanted us to send it through a traditional pharmacy and use their health insurance and their pharmacy benefits, we certainly can. But otherwise, yes, everybody does pay $4 for each script that we have on site at the pharmacy. And yes, I'm looking at the chats. It's all about moderation for your ice cream, right? Yes. Everything in moderation. Surprisingly, not surprisingly, much like the rest of the population, we have diabetes and obesity as some of our largest issues across the organization. Just saw a question about lung screenings, etc. Because of our plant environment, we do have a very robust respiratory programming because of some of our chemicals and ammonia and some things that we have. So those employees who work in those areas, we do fit testing, quantitative and qualitative respiratory testing on an annual basis, depending on the role and their exposure. We don't do any proactive lung screening on site, but again, I would welcome any partnership if there was some to again bring those services on site. We've got the beautiful health center. We've got a lot of employees willing and able to go. So absolutely. Good question.
I'll just jump in real quick. We have one more question, if that's all right. Someone asked, does the company cover any testing services and or physical exam for employees at the wellness center, or is everything billed through the employee's medical insurance?
You know, that's an interesting one, how we do that. So that's a great question. Thank you. Through the health center, nothing gets billed outside of the health center to our Wellmark Blue Cross Blue Shield insurance plan. So if you're seen at the health center for your annual physical, it doesn't actually count against our Wellmark Blue Cross Blue Shield. What's interesting is we're self-funded within our Blue Cross Blue Shield as well. So basically Wells is paying for it, whether it's through that bucket or through the health center bucket. So that's kind of why we do it that way. Now, if somebody wasn't self-insured, excuse me, you definitely could look at that based on the partner you pick for your vendor. Erin, did you see the question about the history of why it's Blue Bunny?
I did. I was just getting ready to answer that. So we have a question that says, what is the history of the name Blue Bunny? So back in the early years after Wells was first started, the owner had a contest and wanting to come up with kind of our mascot. And so the prize back in the early 1900 or back in I think it was 1916, 1917, somewhere around there, they did a contest and somebody submitted a mascot of a bunny and it happened to be blue, and that was the winning icon. And so that's how Blue Bunny came to fruition. And the winner won $25. So that was a lot back then.
I have a question. What type of employee feedback have you had about the program having the on-site healthcare?
Absolutely. It's amazing. Because again, this is a company who believes in their employees. And so to make this investment and try having this on-site clinic was big. When we tour with new employees, every new employee on day one orientation gets to come down and walk through the health center, understand what services they can provide. You just get a lot of really big eyes and oohs and ahs, like, wow, I can't believe they're doing this with me and for me. And then we've also had people who have chosen to leave employment with Blue Bunny, and they'll say, oh, I'm really going to miss the health center. So it is, our employees understand what a great benefit it is and really like to take advantage of it. And like I mentioned, the Henderson and Dunkirk, really getting the health center out to those locations as well for that free or no cost healthcare to our employees has been well received also.
We do have another question. It is, how is Wells working to provide these wraparound health services for all Iowans? I think one of the things that helps us just share our story through opportunities such as today's meeting and making providers and other employers aware of some of the services and programs that we have at Wells. I know we've had the governor has come in and got to tour our facility, our health center. And so it's just education and communication about some of the programs that we have to spread the word across the state.
And these programs would not be possible without the partners, partners like you, partners like Mercy, Everside, because we make ice cream. We make really good ice cream, but we make ice cream. So we need to partner with the experts to bring these services in for our employees.
I can't remember when you said about them not having to leave the job to go get this care. So is this paid time, or is this time that they have to take off when they go to the on-site center?
If it's a personal health issue, then it's unpaid, but they can get, excused off of their shift to go. In the health center with the hours, we're able to cover both day shift and night shift employees. So our day shift employees generally get off around 4 o'clock, and our health center is open till 5:30. And like Tabitha mentioned, they do take walk-ins. So if the employee's feeling, bad, have a sore throat at the end of their shift or at the beginning of their shift, they can stop by the health center because they are open 7 a.m. to 5:30 p.m.
And even within Iowa, we advertise our telehealth services. So when you work at the plant, you get to work and you end up changing into a uniform that's sanitary for food. And so to leave mid-shift, you have to change back into your street clothes, go a mile down the road, and then be seen. So that's why we also promote the telehealth even for our Lamar's campuses, because then you can just jump into a conference room or a private area and use your phone and see the provider that way as well. So we try again to do anything we can to get that access, bring the care to the employee where they are. And honestly, we're going to start having our providers hanging out in the break rooms a little bit more to build that relationship, because if you have that relationship, then they're going to take the time to come and see you before or after their shift or on their day off for those wellness screenings. So.
Looks like we do have another question. What is some feedback you've gotten from your staff about barriers that remain to screening?
I think honestly, it's a lot to do with time. It's a lot to do with priorities. Making it a priority to get those screenings done and understanding the importance of it. And that is where our plant nurses and those educational efforts, I feel like, really come in, because that's where we can help them understand why these screenings are so important, help them understand the little steps they can take along the way that makes such a big difference. And then driving them either to our health center or to their own primary. We don't care where they're seen. We just want them to get seen and get those screenings done.
We have another question. Do you have any success stories around screening, cancers found, things of that nature?
I wish I could tell you a specific story, but they don't really give me specifics because of confidentiality. As far as cancer, I don't have a specific example right on the top of my head, but they were just sharing a story with me about we have an A1C machine, and we caught somebody who was pre-diabetic, and we're able to do the education and the diet and things like that and keep them from going on the meds. We've had plant nurses who caught a stroke very early and got them treatment, and the individual was back at work within 2 weeks because the stroke didn't fully occur. We've had plant nurses identify cardiac issues. You need to get in, and the individual's like, no, I'm not going. And the plant nurse stayed persistent. The individual went to the cardiologist and ended up in surgery like the same day, next day, avoided a life-threatening incidents. So unfortunately, I don't have a cancer story that I can share, but we do have multiple other issues that they have addressed, caught early. So with that, I have to believe there was probably some cancer story in there. I'm just not aware of it.
Yeah, I'm aware of one because
Okay.
the employee came to me from a benefits perspective to talk about, how cancer treatment would be covered and what plan would be best for her during open enrollment to select, because she knew that she was going to be going through. But it actually occurred because of our on-site mammogram program, having the mammogram trailer on site. She had her first mammogram and found out as a result of that she had cancer. So it was a very aggressive form of breast cancer. Happy to share. She's shared her story with me as she's gone through, but she is in remission now. And so that was caught as one of our, a cancer story through our on-site mammogram offering.
I believe we have one more question. We got the question of how many employees use your health center?
So of the 4,000 employees, and then there's spouses and children eligible. So it's hard to say an exact number, but we run around, oh gosh, I don't even want to say without getting it wrong. Consistently 30%, I believe, is the number. But it's somewhere in that area. Plant nurses, it's a lot higher because again, they're right there.
Questions for our wonderful speakers? Okay, if you have them, if you think of some later, feel free to drop them in the chat, and I'm sure we can get them answered.
So thank you. Hi everyone, Mary Charlton. I'm the president of the board of directors of the Iowa Cancer Consortium, and it's amazing to see such a great turnout today and great to see you all. I have the incredible honor of introducing Dr. Laura Beane Freeman, who will talk to us about occupational cancer risk for individuals involved in agriculture and farm work. And Dr. Beane Freeman received her PhD degree in epidemiology from the University of Iowa, which is where I had the opportunity to meet her when we both worked for the same faculty member way back when. I don't even want to say how long ago that was, but it was a long time. And in fact, she was the very first mentor I ever had in my cancer epidemiology career and has provided invaluable advice and support throughout my career. She's a senior investigator for the Occupational and Environmental Epi branch at the National Cancer Institute in Rockville, Maryland. She is also the NCI principal investigator of the Agricultural Health Study, the Early Life Exposures in Agriculture Study, and the NCI Formaldehyde Industries cohort. We're so lucky to be able to hear from her today, and we will have time for questions after her presentation. So feel free to put comments and questions in the chat. And welcome, Dr. Beane Freeman. Thank you so much for joining us today.
Thank you, everybody. I just wanted to point out that we're having some technical difficulties, so I'm not able to share my slides directly, so you'll hear me saying next a lot, but hopefully I won't forget to do that. But I really appreciate the invitation to speak to you today about agriculture and cancer. I think it's really fitting that I'm speaking to the Iowa Cancer Consortium about the Agricultural Health Study cohort, a study that's been going on for more than 30 years and whose goal is to identify agents in the agricultural environment that might influence cancer and other chronic disease risks. This study not only includes participants from the state of Iowa, but also would not have been possible without the collaboration and input from researchers from the University of Iowa, and in particular, the Iowa Cancer Registry. And I want to specifically acknowledge Chuck Lynch, who I'm sure many of you know, maybe he's even on the call today, but he was really instrumental to the success of this study from the very beginning, and continues even after his retirement to be involved in investigations within the cohort. Next slide. But before I talk about 30 years of agricultural exposure and cancer, I maybe just want to talk about my more than 30 years of experience with agricultural exposures. I grew up on a farm in rural Tama County, where we grew corn and soybeans. We raised cattle. We sometimes had hogs and sheep, and like most kids who grew up on farms, I showed my 4-H calf at the county fair. I worked on the farm, I played on the farm, and I think I've experienced many of the exposures that I'm going to talk to you about today. Next slide. I wanted to take a moment to define what I mean when I'm talking about agricultural exposures. Maybe it's not as much of an issue for those of you in the state of Iowa, but oftentimes when I talk to other groups and I talk about agricultural exposures, they're really focused on pesticides in particular, which certainly are very important exposures, but they're not the only exposures that are experienced on the farm. For example, we know that farming is a dusty occupation. There can be animals on the farm, which include their own set of exposures. And many times farmers and their families are using private wells, which may have their own contaminant profile that is very different from regulated public water supplies. And the goal of my talk today is not to focus so much on specific results or individual analyses that we have conducted, but rather to give you a flavor of the kind of work that we're doing, some of the challenges that are inherent in doing this kind of work, what we're doing to overcome some of those challenges, and the breadth of work that we're doing within the cohort to understand and identify etiologic agents for cancer risk. And finally, I just want to say, while we've done a lot of work within our study, no one study, an observational study, is sufficient to really establish causality. So we really want to interpret our results through the lens of everything else that we know in the literature and from other scientific avenues. Next slide. So first, I want to talk a little bit about challenges in studying the effects of pesticides on cancer risk. Again, sometimes when I talk to groups, they think that pesticides are sort of a monolithic group and, you know, they just use the global term pesticide, but it's really much more complicated than that. There are currently over 800 different active ingredients that are registered for use in the United States. Next. But very few have been evaluated formally for human carcinogenicity or other chronic diseases. Obviously, when pesticides come on the market, they undergo pre-market testing as part of the registration process through EPA, but not surprisingly, and actually, I think it's very good that they're not testing those pesticides on humans in particular. And there's also limited data on the post-market health effects. Next slide. Another challenge that we often sort of have to take into account is when we think about what are the mechanisms of action for pesticides. Those of you who work with drugs, you think about a mechanism of action and a target system or organ, but the mechanisms of action for the pesticides are really relevant for the target pests that they're designed to control that may or may not be relevant for human disease. So one example is the organophosphate and the carbamate insecticides. These are insecticides that kill the insects by inhibiting acetylcholinesterase. That probably isn't relevant for cancer risk. The jury's still out, but I think it probably isn't the most important thing. It may be relevant, for example, neurodegenerative diseases, for example. Next. Another example are the triazine herbicides, the most common of which is atrazine, which you may have heard about. It kills weeds by inhibiting primary events in photosynthesis of chloroplasts. Also probably not really relevant for human disease, but it's been noted that many of these herbicides have endocrine disrupting properties, which may be actually relevant for carcinogenesis, particularly for hormonally sensitive cancers. Next slide. Another thing that we have to take into account when we're thinking about pesticide exposure and that may influence the level of pesticide exposure are different agricultural practices. That includes different application methods, the use of personal protective equipment. We know that pesticides certainly come with a label that says how you're supposed to handle them and how you're supposed to use them, but we also know that that is not necessarily the way that people actually perform. For example, this photo in the bottom left shows people on a bean buggy who may or may not be related to me and definitely not following good practices. They have exposed skin, they're not wearing gloves. They definitely have a higher exposure than one would expect based on the label usage, while the person in the tractor driving the buggy is sitting in an enclosed tractor cab with probably a HEPA filter and may actually have very little exposure. Next slide. Another thing that we have to take into account is change in pesticide use patterns over time. I'm just showing this animation that shows two chemicals that are very similar in chemical structure, or two herbicides, allichlor and acetochlor. Acetochlor was registered for use first in 1992, and you can see as through the animation, there was essentially no use at that time. But when the EPA registered allichlor for use, or excuse me, acetochlor for use, they specifically took the unusual step of saying that they anticipated that the use of allichlor should come down, and they wanted to see that because they felt that it was a toxic chemical. So we really need to take these things into account. Next slide. So how can we study the effects of pesticides on cancer risk? First, we need information on specific active ingredients. As I've shown you, these chemicals are really very different. We need a highly exposed population so that we actually have the ability to look at exposure contrasts in order to pick up risks. We need accurate characterization of exposure for exposure response analyses. And we need a large population and long-term follow-up, particularly for cancer. Unfortunately, cancer is still a rare disease, so we need a really big population. Next slide. So all of these factors were taken into account when the agricultural health study was designed. The AHS has been a collaboration of 4 federal partners: the National Cancer Institute, the National Institute of Environmental Health Sciences, the Environmental Protection Agency, and the National Institute for Occupational Safety and Health, as well as numerous extramural collaborating centers such as the University of Iowa and other universities. And it really has developed into the preeminent cohort for cancer evaluations in the world, focused on agricultural exposures. The study includes about 57,000 licensed pesticide applicators, and by pesticide applicators, I mean mostly farmers, who were enrolled in 1993 to 1997. So when they were applying to obtain or renew their licenses to apply restricted use pesticides. We estimate that actually about 82% of the people who were applying for licenses at that time enrolled in the cohort. So we think this is very representative of the farming population in the mid-1990s. We also enrolled about 32,000 of their spouses. The study is conducted in Iowa and North Carolina with about 65% of the cohort from Iowa. And as I mentioned, the goal of the study is really to understand factors that influence the risk of cancer and other diseases in farming and agricultural populations. Next slide. This schematic just is sort of an overview of the study to date. As I mentioned, enrollment was in the mid-1990s. At the time of enrollment, the pesticide applicators / farmers provided a detailed pesticide history. And we've conducted follow-up interviews about every 5 years since. And one of the hallmarks of the Ag Health study is its detailed assessment of lifetime use of numerous pesticides combined with an intensity weighting algorithm that takes into account factors that impact exposure levels, such as the use of personal protective equipment, application method, et cetera. And this is really supported by some field studies and efforts that were conducted by EPA and NIOSH over the years. We also update our cancer experience of the cohort by regularly linking to cancer registries in the state of Iowa and North Carolina. Fortunately, the population is relatively stable. The last time I checked, there was fewer than 4% of the population that had moved out of one of those states, which is not surprising given that these are farmers and really tied to the land. Since the mid-1990s, we have observed over 10,000 incident cancer cases in the applicators and about 5,000 cases in the spouses. And this is really important because we're able to look at more rare cancer outcomes that we're not able to do in previous studies. And this really represents like the long-term investment in this cohort study over the last several decades. Next slide. We also conducted a molecular epidemiologic sub-study called the Biomarkers of Exposure and Effect in Agriculture. The goal of this study is really to provide support for the biological plausibility of the observed findings in the overall cohort. And we recruited 1,700 male farmers from the AHS who had completed all previous questionnaires in the study at the time that BIA started. And then we collected blood, urine, buccal cells, and house dust for really more detailed investigations of biological plausibility. Next slide. So now I'm going to talk about the cancer experience in the cohort. Next slide. So this table shows the cancer rates in the Ag Health Study farmers compared to the general populations of Iowa and North Carolina that have been standardized for age and sex. And one thing that you might I want to draw your attention to is that there is an overall deficit of cancer overall in the cohort. And this is really not surprising. This is something that has been observed in many other settings. Farming populations generally have lower cancer rates. They tend to smoke less. They tend to be more physically active. But it's also a function of something that we just see in occupational cohorts in general, where people who are healthy enough to work are healthier than the general population. So this is not a surprise, but it's something I think to keep in mind when thinking about cancer experiences in this cohort. But just because there are deficits compared to the general population, that doesn't mean that we can't still conduct studies within the cohort to identify etiologic factors that contribute to cancer risk, even if there are deficits overall. Next slide. So there are also some excesses. In particular, we see an excess, a relatively small but significant excess of prostate cancer. This also has been observed in other farming populations. And so it's been a cancer site that we've been very interested in. Next slide. There are also a few other sites, including cancers of the testes and thyroid, as well as some other lymphoma subtypes where we see suggestion of elevated risks. Next slide. This table is the comparable table, but just within the spouses. And so again, comparing the cancer rates in the spouses to the general populations. And again, we see this decreased risk of cancer overall. 60% reduction in lung and bronchus cancer. This is something that we also have seen in other farming populations. Next slide. But again, there are certain sites in which there's excess, including melanoma of the skin and uterine cancer. Next. As well as some additional sites where there is suggestion of excess risk. Next slide. So now I'm going to talk a little bit about what we found for pesticides and cancer in our study. Next slide. But I'm not going to show or focus on specific pesticide cancer relationships today because really we would be here all day and we only have a few minutes. So instead, this is just a listing of some of the papers that we've published on pesticides and cancer in the last 10 years. It's really clear that while some pesticides seem to increase the risk of a few cancer sites, there isn't a pesticide that increases all risk. And there doesn't seem to be, a site that where we see a bunch of pesticides that increase risk. So, it's really critical to investigate the specific pesticide active ingredient associations with specific cancer sites. And it's really also critical that we follow up on these evaluations and observations, looking at biological plausibility. Next slide. So the importance of the AHS findings on pesticides and cancer have been recognized by agencies that regulate pesticides. For example, in 2016, the EPA Office of Pesticide Programs, which is the part of EPA that is responsible for actually registering pesticides and regulating them, put out a framework for incorporating epidemiologic data into their risk assessments, which they do periodically on every registered pesticide. And they noted that in the past, they've relied primarily on toxicology studies in laboratory animals, and then extrapolated that to human health risk. But they actually specifically called out the publication of the papers from the Agricultural Health Study for the first time being able to use epidemiology in their risk assessments on pesticides. So we feel like this is really important because we think that you can learn a lot from rats, but we think that actually conducting studies in humans is really important. Next slide. Our results have also been used by other agencies, such as the International Agency for Research on Cancer, which is an arm of the World Health Organization. In 2015, they conducted reviews of the carcinogenicity of several pesticides, and results from our study played an important role in the evaluations where they classified lindane and organochlorine insecticide as a group 1 or known human carcinogen, and several other pesticides as a group 2A or probable human carcinogen. Next slide. So if you have a specific cancer site or a specific chemical that you're interested in learning more about, we have a website where all of our publications are listed. Not all of our publications are focused on pesticides, and not even all are focused even on cancer. We've evaluated a lot of other health outcomes as well, and we've done a lot of research on non-agricultural exposures within the study. But if you are interested, you can go to our website here, aghealth.nih.gov, and you can look at any of our publications. Next slide. So I want to shift gears a little bit and talk about some ongoing and future work, both in pesticides and other agricultural exposures. First thing I want to talk about is health effects of pesticides in women. A lot of the studies of pesticides in cancer have been conducted almost exclusively in men because they've been done in sort of like occupational or farming populations, and those tend to be predominantly men, although of course we know that women are also working on the farm. But we think that the spouses of the Ag Health Study farmers really represent an opportunity to kind of understand risks in women and non-occupational exposure to pesticides more fully. So we have about 32,000 spouses of the farmers. Almost all of them are women, greater than 98% of them. 60% of them said that they used pesticides at some point in their life. When they enrolled in the study, they all were married to a farmer who applies pesticides. That's how they got into the study to begin with. And so they really represent a potential for non-occupational exposures. Next slide. We think that these women represent a high level of general population exposures, particularly in rural populations. And so working with exposure assessors at the NCI, we developed an algorithm to estimate exposures from routes other than the personal application of these pesticides, including how close their homes were to fields where pesticides were being applied. So we can look at agricultural drift, para-occupational or take-home exposures, so that, you know, this is the farmer coming into the house where he has maybe spilled pesticides on his shoes or his clothes, and they're being washed in the washing machine, and also taking into account residential use of pesticides. Next slide. So I now want to shift my attention a little bit to think about some of the other agricultural exposures that are experienced on the farm. Next slide. And I want to talk about biologically active deaths or endotoxins. And I think this is a really interesting exposure because it's sort of, you know, not all exposures increase your risk. And so I think this is a really interesting sort of example that I want to talk about. Next slide. So that we know that farm populations have lower lung cancer rates. You may remember from the tables that I showed you, we had about a 50% reduction in lung cancer rates among our farmers compared to the general population. And certainly some of this is due to lower smoking rates. Next. But there's a hypothesis that it may actually have some other exposures that may contribute to this, and that is endotoxins. Endotoxins have been linked to lower lung cancer rates in other occupational studies, for example, in cotton textile workers. Endotoxins are components of gram-negative cell walls. They're found in agricultural settings, and particularly in areas where animals are residing or where there's stored grain or hay. And in a previous analysis within the study, we showed an inverse exposure-response relationship between increasing number of animals and decreasing lung cancer risk. sort of pointing to the idea that maybe there's something going on with those animal exposures and that it might be endotoxins. Next slide. So this schematic just graphically represents this 50% reduction in lung cancer risk in the cohort overall. Next. But if you look at the stratification by endotoxin exposure or non-endotoxin exposure, this is really a crude metric based on surrogates of exposure. We see that there's a 58% reduction in risk of lung cancer in the endotoxin exposed compared to only a 20% reduction in the endotoxin unexposed. Next slide. But what I think is really, really interesting here is when we looked at the smokers within the agricultural health study. So obviously we know that smokers have a very high risk of lung cancer. Even among the smokers in the agricultural health study, compared to general population made up of smokers and non-smokers, they still have a reduced risk of lung cancer, which is, sort of astonishing to see. And you can see that that really is driven by the people who have endotoxin exposure, and the people who are unexposed to endotoxin actually still have that increased risk that we would expect. Next slide. So this is just a little example of where we took that observation and tried to get more at sort of some of the mechanistic or biological plausibility of this observation. And we know that raising hogs has a very high level of endotoxin exposure. So within our BIA study, we evaluated whether raising hogs was associated with circulating immune markers that have been previously associated with lung cancer risk from other studies. And you can see that in these 4 immune marker panels, we see an exposure response with increasing number of hogs on the farm and levels of these markers. So again, this just provides some further support for the idea that there is an immune mediation that happens with endotoxin exposure and lung cancer risk. Next slide. I want to just also talk a little bit about the work that we're doing in water contaminants. We know that at enrollment, about 70% of the cohort reported that they were using private wells, which probably isn't surprising to any of you. We know that there has certainly been a move toward moving from private wells to rural water supplies over time. But we're very interested in contaminants, particularly in private wells in the cohort. We have geocoded the residences of all of the participants in the study, and we've linked them to their water source. They reported their water source, whether it was a private well or a public water supply. We've linked those residences to the public water supply data, and we developed models for a number of contaminants, including nitrate levels. And we currently have a number of ongoing projects to evaluate cancer risks associated with nitrate levels. Next slide. We're also doing some work to investigate whether or not living near concentrated animal feeding operations might influence risk. We know that personal or occupational exposure to animals may influence the risk, but raising animals may also pose risks to those who are environmentally exposed. I know that I'm not telling the people in Iowa that large-scale industrial farming of animals is becoming increasingly common. And these animal facilities may be the sources of several environmental emissions, including the fact that manure is often sprayed on the fields. There's the possibility of lagoon leaks and just air toxics. Many of the studies of concentrated animal feeding operations have really focused on more acute effects or some of sort of the nuisance effects, such as odors, things like that. But there's actually very little data out there about the long-term health effects of living near concentrated animal feeding operations. So again, we've geocoded all of the residences in the cohort, and we've utilized data from a variety of sources, including the Department of Natural Iowa DNR, with permitted animal feeding operations. Next slide. And we've conducted a series of analyses looking at residential proximity to number of animals. And this may be a little confusing. Animal units is just a standardized unit of an animal, so that you obviously could have many more chickens in a confined area than you can of cows in the same area. So an animal unit is just a standardized metric. So we looked at residential proximity to animal units within 5 kilometers here and risk of non-Hodgkin lymphoma. We took into account whether or not people were raising animals themselves, because we wanted to sort of get rid of the effect of raising animals themselves. And we don't really see any clear patterns of risk with non-Hodgkin lymphoma with increasing number of animals overall. Next slide. But then when we looked at animal types individually, next, we see that there is an increasing risk of NHL with increasing number of cattle in particular. So this gives us some interesting clues about things that we might want to further investigate, and we're currently conducting efforts focusing on developing models for specific pollutants and for tumors other than lymphoma and leukemia. Next slide. And I really just want to end then with talking about early life exposures and potential future cancer risk. We know that in the Ag Health study, 92% of farmers grew up on a farm, 60% of the spouses grew up on a farm. We know that farming is, it's a family occupation. And then we know that kids work and play on the farm. Next slide. In an analysis that we did within the cohort, we found that growing up on a farm was actually associated with an estimated 50% increased risk of future lymphomas, which gives us some interesting clues that we might want to further investigate. Next slide. So with that in mind, we have designed and are about ready to launch the Early Life Exposures in Agriculture study, which is a cohort of the offspring of the AHS participants to evaluate early life exposures in cancer in childhood and early adulthood. Next slide. We've currently identified about 60,000 adult AHS offspring. Given that the original Ag Health study cohort was enrolled in the mid-1990s and they were in their early 40s at that time, their children are no longer children. But we think it's still really valuable to create a cohort of their offspring. So we've developed an online questionnaire of early life farming exposures and activities focused on exposure to pesticides and animals that were grown on the farm, crops, the kinds of farm equipment that they used. We'll also look at other risk factors and outcomes. For example, we know that there are hypotheses about childhood allergies and asthma that may later influence cancer risk that we'll be able to look at. And we'll be able to combine these data with information from the agricultural health study cohort parents on their own exposures, medical conditions, and medication use. Next slide. So just sort of in conclusion, we know that farming populations experience a large number of exposures related both to their work on the farm and the fact that they're living in a rural environment. Pesticides are obviously very important, but there are many other exposures that people may have that may be sort of unique to a rural or agricultural environment. But we think that the results may be important and applicable to other populations. And finally, I just want to say that all of the work that I've talked about is really not possible without a multidisciplinary team of exposure assessors, epidemiologists, statisticians, and a whole army of people really that are needed to capitalize on the data. Next slide. Back in 2018, the director of the NIH recognized the Ag Health Study team for its sustained work in this area, which was a great big honor for all of us involved. Next slide. And I feel like I have a long list of collaborators here, but it really is only a fraction of the people who have been really important to the success of the study over the last 30 years. But I did want to acknowledge some of them specifically. Next slide. And as I mentioned earlier, if you want more information about the study, we have a website where you can peruse all of our publications. You can learn more about the study. We put out a newsletter for our study participants every year, and of course are open to scientific collaboration as well. Next. And with that, I would be very happy to take any questions.
Thank you so much, Dr. Beane Freeman. That was outstanding. I know Dick Deming is very keen to ask you a question, so we're just going to jump right into it. Go ahead, Dick.
Well, thank you. Wow, Laura, thank you so much. I really appreciate it. I was aware of the Ag Health study and read a little bit, but this just really informed me a lot. So I got so many questions, but a couple. So I'm going to throw a few together. One of the last slides was that 50% increase in non-Hodgkin's lymphoma and I think that was like offspring, but so all of your talk is mostly like, well, we can't show much of any increased risk, and then all of a sudden there's a 50% increase. So one of my questions in general is, what is the cohort that we're comparing to? So what is the relationship between a substance and cancer? Is it a dose? The higher the dose, the more likely, or is there a minimum threshold? And so if all of us in Iowa that drink water from Iowa are getting a little bit of everything, I mean, that would be, you could come up with a theory that you're not going to see increased risk for the farmers compared to those of us who are city slickers but drink water that might contain it. So that would be just sort of one general question. Is the cohort that aren't people exposed, farmers exposed, are they Iowans who are perhaps drinking water? Also, it seemed like all the data was pesticides, and I don't think your term pesticides, it includes herbicides and insecticides, but doesn't include fertilizer. Is fertilizer something you're studying? And so I'll stop there with those.
Yeah. So let me go in the order that you asked the questions. So the 50% increased risk of non-Hodgkin lymphoma was comparing people in the cohort who grew up on a farm to people who didn't grow up on the farm. But we have a relatively small number of people who didn't grow up on a farm who then are farmers, right? And mostly that's among the women. So I think that that's intriguing, but it's not, it's not a smoking gun, so to speak, right? So that analysis was really within the cohort, looking at people who grew up on a farm that may have had early life exposures that may increase their risk later in life, right? So that's that analysis. And I didn't want to leave the impression that we didn't see much for pesticides. You are correct. The pesticide analyses are insecticides, herbicides, fungicides, and fumigants, and not the fertilizers directly, although we are doing this work on nitrate levels in the water. So for those analyses, we actually really think about exposure response. So, we are comparing, in the pesticide analyses, we are comparing the exposure to atrazine, for example, people who are using atrazine compared to people in the cohort who are not using atrazine. So those are all internal comparisons. So they are presumably living and working on a farm, but they're just not applying atrazine or dicamba or diazinon or whatever the specific chemical that we're looking at. And we really are looking at exposure response, right? So, and when we're doing this, we are looking at their occupational exposures to these pesticides. So they're using and applying the pesticides because, those people probably have the highest risk, highest exposure of anybody compared to someone who maybe have some, atrazine in their well, for example, because probably the people who are using atrazine also have atrazine in their well. So that is really what we're looking for, and to really to sort of make more strong conclusions, we look for effects of exposure response, right? If you have more exposure, you have more risk. And we are really focused on those farmers because of these issues around how do you assess the exposure to someone, to a specific chemical over the decades of that it may take for cancer to develop, right? So that's why we're really focused on the farmers. And so then once we establish, or we think that we've established, or we see this observation with, let's say, turbofos and prostate cancer risk, which is something that we've seen, then we think, okay, well, what are the biological mechanisms? Is this a chance finding, or is this something real? And then we think, well, can we extrapolate this to other populations or people who may be lower exposed? So this is sort of, on the continuum of how do we establish causality. I don't know if that answered all of your questions.
Well, it did. And if I could ask just one more, and this is a little bit telling, at what point does do we say, for example, smoking causes cancer? Obviously, it took years and decades, and now nobody that I know refutes that.
Right.
Maybe do you think that the science between Agent Orange causes cancer, was that really the science, or did we make a political decision? And at what point does the data, I mean, do you have sufficient data on that prostate cancer that we say, yes, this chemical causes prostate cancer? At what point does the data sufficient for the scientists to say yes, and and it may be a different threshold than the politicians saying yes?
Right. And that is a very important question. And as you said, it's sort of a philosophical, political discussion about regulation. So let me say a little bit about how do we decide something causes cancer. And this is, I want to refer back to, I don't know if you remember, I showed a slide about the International Agency for Research on Cancer that had done evaluations of pesticides. And so what they do is they take the totality of evidence, they look at animal studies, they look at mechanistic studies, they look at experimental studies, and they look at human cancer data. And frankly, there is relatively very little data on pesticides and cancer in humans. There's really not many studies that have been done because of these challenges with the exposure assessment, like I mentioned. So, IARC does these evaluations, they really are focused on not what is the dose, not anything political, but given all of the totality of evidence, does turbofos cause cancer? Does it cause prostate cancer? And they make a determination of yes, probably, possibly, not enough data to determine, right? So, it really goes beyond the scope of any one study to be able to do that. And so that's why I think those kinds of evaluations are very important. And I think it's also very important that EPA is now considering human evidence because in their risk assessments, because before, as they said themselves, they didn't even really consider human data when they were doing their risk assessments for the registration of these pesticides.
Thank you.
Thanks, Laura. Unfortunately, I think have to go to a break, but I did want to echo what Rachel said in the chat that we're just so fortunate that the study happens in Iowa and that we have you and the whole agricultural health study as a resource to learn about this. For Iowans, as you know, we have high cancer rates here, and they're increasing, and people are increasingly asking questions about our environment. So this was incredibly helpful. And I'm sorry, Diane, we didn't get to your question about schools, but we are going to put Laura's email, I think, if that's okay, in the chat, so that people can follow up with her questions. And I will turn it back over to Liz to get us to the break. Thank you, Laura.
I think we're going to kick it over to Kelly, actually.
We're
juggling
here. So we have a flurry of texts going between our staff too. I just want to say, and of course we haven't talked to Dr. Beane Freeman about this, but we would love to get her back in front of this group and the network for those who are interested, because obviously there's so much information that folks want to talk about, and we want to make time and space for that. So just know that we'll be cooking up some ideas. And Dr. Beane Freeman, thank you so much. And hopefully we can convince you to come back and talk to Iowans again really soon.
Yeah, I would be happy.
Laura for the Iowa Cancer Summit. that's my vote. Come back in October with the director, then CI.
Yep, perfect. I think there'd be lots of folks who would be excited about that. So we'll talk. More to come.
Great, thank you.
Yeah, so thank you so much. And we are going to take about a 5-minute break. So it's a little shorter than planned, but so quick 5-minute leg stretch. And then we will get started at about, it looks like 12:35. Thanks, everybody. All right, welcome back, everybody. We have still a lot of really good content to go. And to get us started for this next half, it is my pleasure to introduce Sarah Zeidler, who is with Unity, the executive director of Unity Point Stoddard Cancer Center. She is on our board of directors, importantly, and she is going to introduce our next session, which is a panel discussion about carcinogenic risk for firefighters. Sarah?
All right, thanks, Kelly. So today I'm excited to introduce Dr. Judith Graber and Lieutenant Tyler Mark. Dr. Graber is an associate professor in the Department of Biostatistics and Epidemiology at Rutgers University in New Jersey. Her research examines cancer risk and risk factors among volunteer firefighters with the long-term goal of reducing cancer incidence and mortality among all firefighters. She is the principal investigator of the FEMA-funded Firefighter Cancer Assessment and Prevention Study. And then today we also have Lieutenant Tyler Mark. He is a firefighter and paramedic for the city of Des Moines. He is an International Association of Firefighters power fitness instructor, a hazmat technician, and a rope rescue technician. On his off days, Mark is an instructor for fire science and EMS programs at Des Moines Area Community College. We will learn a lot more about each of our panelists during the discussion, so thank you guys for being here. While we're going through the session, please put any questions for our panelists in the Q&A feature. So welcome you both, and Dr. Graber, will you get us started here?
I would be happy to. Thank you so much. I'm going to share my screen. Can folks see that? And is it in presentation mode?
Yes.
Awesome.
Yes.
Okay. Thank you so much. I'm so excited to be here and so excited that the Iowa Cancer Consortium is addressing occupational cancer in today's session. I'm going to, as Sarah said, spend some time talking about firefighting and cancer, about 10 minutes, maybe 11. So I'll talk briefly about the U.S. Fire Service. I'll talk about what we know about firefighters and cancer risk. I'll say what I think are some research gaps, and then briefly give 2 examples of many of the ongoing efforts to address this issue. So, in the United States, there are about 1 million firefighters. About 65% of those serve as volunteer firefighters, and volunteers tend to serve in more less densely populated areas or suburban and rural areas. So not surprisingly, in Iowa, you have about 92% of your firefighters serving as volunteers. The U.S. Fire Service has historically been overwhelmingly non-Hispanic, white, and male, but it is evolving and diversifying and increasing diversity both in terms of gender and race ethnicity. Now, Dr. Beane Freeman did a wonderful job of explaining how IARC works in terms of categorizing preventable causes of cancer as to their carcinogenicity to humans. So IARC first reviewed firefighting as a human carcinogen in 2010 and classified it then as possibly carcinogenic to humans based on the evidence. Since that time, there's been a lot more evidence about firefighting and cancer, including the kinds of exposures that firefighters are incur during live fire exercises and trainings and responses. So things like combustion products, diesel exhaust, asbestos, chemicals like PFAS and brominated flame retardants, shift work, and ultraviolet radiation. So many known human carcinogens in their work as firefighters. Well, in 2022, IARC re-reviewed firefighting, and both Dr. Beane Freeman and I were honored to be as part of this panel. And based on the evidence, the epidemiological evidence, we classified occupations of firefighting as group 1, as carcinogenic to humans. And this was based on evidence, particularly strong evidence for mesothelioma and bladder cancer, so sufficient evidence for humans in those cancers, and then limited evidence for cancers of the colon, prostate, and testes, as well as melanoma and non-Hodgkin's lymphoma. And I think it's important to understand the way IARC uses limited means that there is a credible positive association, but you can't quite rule out an influence of confounding or bias or random error. There was very strong mechanistic evidence for carcinogenicity of firefighting based on these key characteristics of carcinogens in humans. And then importantly, the group was very clear that this finding responds to, applies to all firefighters, although most of the research done on firefighters is done in career firefighters, and I'll return to that point in a minute. But I do want to say that there are standardized ways, recommendations for firefighters reducing that exposure after responding to a live fire event or participating in training. They're supposed to establish an area on scene, and then they wipe each other off with his brush and ideally water and soap, but you can do a dry scrub off too in those very cold winters, for example, in Iowa. You'll notice these firefighters are on air, retaining that safety for respiratory protection. Then they rinse off. They doff or take off their gear in a prescribed way to reduce secondary contamination. They use wipes to get at that skin contamination. The gear is bagged. It goes back to the fire department where it goes into a industrial extraction washer. And then they're supposed to shower within the hour. So these are the recommendations. Now, keep those in mind, and also that what I said a few minutes ago, that almost all the research on cancer in firefighters is from studies on career firefighters. So you ask, why? 65% of US firefighters serve as volunteers. Well, there's great reasons, right? Career firefighters, you go to the firehouse. If they're not out of the fire, on a fire, they are there on shift. So you have access to them. And as epidemiologists and scientists, you also have access to occupational records and sometimes union records. So their exposure records, their employment, even health monitoring, all the things we need to really understand that historical exposure. And in volunteer firehouses, you often don't have that information, and you certainly don't have that access. There's also a belief among some career firefighters and some researchers that volunteer firefighters don't get that kind of the same kind of exposure and as much risk as career firefighters. So I spent a lot of time in a coalition working closely in my research with volunteer firefighters, thinking about how cancer risk might be similar for volunteer and career firefighters and how it might be different. So we have a few buckets we think about. One of those firefighting exposures. Now, volunteers do on average respond to fewer calls than career firefighters, but they tend to both stay in the fire service longer and stay on each fire scene longer. Organizationally, volunteers are on call 24/7 versus very prescribed shifts. And they have much less access generally to health monitoring occupationally and to the physical fitness support. In terms of protection, they all wear that same protective gear, but those decontamination procedures I talked about are less known about and less used in volunteer environments. And then some of this other stuff like showering within the hour, most volunteer fire departments don't even have a shower, never mind the time to take a shower. And diesel capture is also very less common in volunteer stations than career stations. And then there are a bunch of modifiable risk factors that you can think about with firefighting. Volunteer firefighters generally have a lower level of physical fitness, higher body mass index, higher abuse of alcohol, and higher levels of cigarette smoking compared to career firefighters. And let's think about these modifiable risk factors, because when IOC talks about occupational risks, they're talking about those exposures from the fire scene. But there's other things as an occupational epidemiologist that I think are important because they are connected to firefighting. So firefighters are basically performance athletes. They go from 0 to 60 when they respond. They have very high caloric diets because of that, and often diets low in fruits and vegetables. As they age and move away from the physical activity of the first response into leadership, they can put on BMI, and we see BMI much higher on average in volunteers than career firefighters. It is clear that this is a very stressful job and that there is a fair amount of alcohol abuse among firefighters. Again, levels are almost twice as high in our studies among volunteers than career, although higher than the general population for both. Both groups use smokeless tobacco at much higher rates than the general population. And of course, we talked earlier about shift work or sleep disruption. So there's a whole bunch of modifiable risk factors that we also have to think about. So what do I think are the gaps right now? Well, certainly we need more information about the mechanisms. I think particularly epigenetics and inflammatory pathways. I think we need to understand some of these exposures, particularly mixtures, and then the efficacy of the current recommendations to reduce those occupational exposures that I showed a few minutes ago. In terms of cancer incidence and mortality, we need to know more about these less common cancers, understand the influences of confounding and bias, and the intersection with those modifiable risk factors. And then there's a lot of smaller populations, women, diverse populations in the fire service that would be great to be able to understand specific cancer risks for. I'm going to very briefly tell you about 2 programs in the U.S. that are looking at firefighter cancer risk, although there are many. The National Firefighter Registry for Cancer, run by the CDC, and for disclosure, I do sit on their National Advisory Board, and the National Firefighter Cancer Cohort Study, and I am on their co-lead board. So both of these aim to understand cancer and its causes in order to reduce cancer in firefighters. Both are really close collaborations with the fire service, and both enroll all types of U.S. firefighters. But there are some differences. The research, the Firefighter Cancer Cohort Study, were really focused on early carcinogenic processes and exposures, whereas the National Firefighter Registry for Cancer is focused on cancer diagnoses and outcomes. They both collect survey data. The National Firefighter Registry for Cancer is going to use that data to link with cancer registries and death registries, the National Death Index. The Firefighter Cancer Cohort Study also collects biological samples. And then finally, of course, the FFCCS is a research study, and the NFR is more of a registry. The research the FFCCS is looking to enroll 10,000 active firefighters. We've enrolled 5,000 so far, and the NFR is looking to enroll over 200,000 firefighters. So that's just some information about a couple of the efforts out there, and I'm really looking forward to the discussion and questions. Thank you.
All right, thank you, Dr. Graber. I think we'll transition now to Lieutenant Mark for your opening comments. Thank you.
Yeah, thank you guys for having me. It's exciting to be here and being a group of people that want to talk about cancer. It might not surprise you, but it's not the most popular topic around the firehouse kitchen. But a little bit about me. So I've been with the Des Moines Fire Department about 7 years. I've been a lieutenant for just a few months now. I grew up in the fire service. My dad was a volunteer for over 30 years here in the state of Iowa. So definitely familiar with both sides of that table. And I can tell you this much, fire doesn't care if you're volunteering or if you're getting paid. So the risk and the carcinogens are just as great for those men and women as they are for us that are getting paid to do it. So after high school, I went on to college, actually got a degree in construction engineering, spent about a decade in the construction industry before returning home to join the fire service. So that was around 2015, I started that process, got the paramedic certification, and then got hired with Des Moines. Where we talked a little bit about the peer fitness support through the IFF. That's a big group of people around the country that is focused on the health and wellness of firefighters. Big risk factor for firefighters always used to be the concern of heart disease, and now cancer is kind of taking the forefront. The statistics show that we're far more likely to have issues with cancer than with heart disease. But the modifiable risk factors, that's a big focus of the peer fitness trainers, is getting people active on and off the job. So in the sense, when we're on shift, we know we're going to be exposed to greater risks. We know we're not going to sleep well at night. Our eating is going to be interrupted. You might not eat at all. Your hydration, all those things are kind of at the whim of the city at the time. But it's trying to control our risk at home, making sure that we're getting the best sleep we can, that we're working out, that we're not engaging in the carcinogenics of the alcohol and the tobacco. I can proudly say that there's about 312 members of the Des Moines Fire Department. I don't think any of them smoke. A lot of smokeless tobacco, but it is improving. So we're making some progress there. Hazmat technician, I think, is a direct correlation as well. We talk about modifiable risks and reduction to these exposures. And people see hazmat and they think this big, scary cloud of chlorine chemicals that is filling the city or whatever. But realistically, our fires are the most hazardous calls will go on versus any possible hazmat scenario. So our hazmat technicians, we're trained to go slow, reduce the risks, engage the problem, solve it, figure it out, whatever we have to do to stop it or reduce it. But if you put a fire behind a door and you'll have a row of firefighters going to bust through that door to try to go take care of it, whereas the chemicals and the exposures in that fire scene are far more deadly and hazardous to our health than any hazmat scene. So it's kind of a mindset. The doctor talked about it before, just a mindset of acknowledging those risks. And then there's a lot of things we can do on the outside of that. So fortunately, 7 years ago, even like the decon process the doctor talked about with cleaning yourself after, on air, dry brush, wet brush, taking care of your gear, having it washed and extracted, and then coming back to the fire station, that's gone from nothing in the Des Moines Fire Department to where we're very well engaged in that same exact process. We are just now in the process of getting our second set of gear so that if you go to a fire in the morning, you can take care of your gear, have it clean during the day, and then you can get back into a new set of gear. Whereas before, you could go to a fire, you show up at 6 o'clock in the morning, you could go to fire at 7 o'clock, and that exposure is sitting with you all day because you don't have anything to change into, or you don't have any way to clean that. So we are improving. And there's a huge factor with communities, full-time and part-time volunteers. There are some remarkable volunteer departments in the state of Iowa that have far more services than we do in Des Moines. And there's obviously the opposite end of that spectrum where there's people that don't even have extractors yet. So it's important to be aware of that and do what you can. I was watching some of the questions go through and was talking about the volunteers taking that stuff home with their families. And maybe the doctor can help me with the statistics, but I know children of firefighters are at extremely much higher risk of cancer than non-firefighter families. So I don't know the numbers exactly, but I know it's pretty ugly. It's pretty scary. So I'm very aware of that. I try to take a shower before I leave work. I leave all of my equipment and all of my gear at the station. If I have to go to a different station the next day, it's contained in a special container or bag that's supposed to keep all that in tight to it, so that I'm not bringing it home to my family. So definitely concerned there with our families. In addition to all those things that I do with the fire department, I'm a fellow with the National Fallen Firefighter Foundation, which is making sure, the task is every firefighter goes home safe. Modifiable risk there with disasters on fire grounds, line of duty deaths that happen from trauma or fire or collapses. But they're also making a huge push to on the cancer front. And then, yeah, I think that's probably it for an introduction on me. If there's any questions or if we want to jump into some of the other topics.
All right, it looks like we do have a couple of questions in the comments here. One question from Dr. Wiener: do we know about relative risks for structural versus wildland fires, given the significant but different exposures? Full disclosure, my son is a wildland firefighter. Yeah.
So that's a great question. And so in general, the IR work group did say that the cancer risk really is across firefighters, but that question of the different exposures for the subgroups, I think, is really important. There is a study now, one of our firefighter cancer cohort study subgroups is looking at woolly and wildland. And I think that's going to be one of the first studies out. There are some studies in Australia that have looked at wildland, but there's just not a large accumulation of evidence yet. I think the take-home message is firefighters really need to protect themselves against exposure, whether they're woolly, wildland, or woolly is wildland urban interface. So that's like where you have people moving into the forest and living, and then fire comes, and you've got this interface where you've got both the wildland and the urban together. The exposures are different, and we don't have a good enough understanding on them. And I think the take-home message is that firefighters are at risk of cancer, and we have to do everything we can to protect them. It's much more difficult in the wildland situation. I'm sure Lieutenant Moore can talk to that. In terms of what the exposures are and what the challenges are of doing reduced exposure when you're out away from a firehouse for days at a time. Very different situation.
Yeah, for sure. And the wildland, I mean, they're out there on their own, isolated to the point to where we can come home. Like I said, fortunately, we're now starting to get that second set of gear to where I can go to a call, I can get rid of that gear, I can take a shower, I can clean myself off. I can do all the wipes and everything that she talked about, but then I can go and get a fresh set of gear and start over. Whereas wildland firefighters, what's burning around them might not be as toxic, but it's still, superheated gases and fumes that they're enriched in and engrossed in for days, if not weeks. So there's technology out there, the fire wipes and things that will kind of give them a little bit of help as far as getting some of that stuff off their skin. But yeah, definitely very different beast, and I'm very fortunate to work in a city where there's not a lot of wildland, because that's a whole nother task. So I appreciate everyone that does that.
Yeah, and I do want to just reiterate that we do have work going on with wildland firefighters. Our research model is an engaged research model. So we have researchers who are out in the field, and we train firefighters to collect samples so we can understand these exposures better. So it is a difficult problem.
Yeah, my son certainly speaks about, coughing up soot for days after being on a fire for a long time and not being able to shower for a long period of time as well. So thank you.
Sure.
All right, Dr. Deming, looks like you have a question.
Hi, Dick Deming, Mercy One Cancer Center, Des Moines. A question, Dr. Graber, and then maybe, I'm sorry, is it Tyler Mark or Mark Tyler?
Tyler Mark, Lieutenant Tyler Mark. Yeah.
Okay.
Whatever works. It's been a long time like that. So whatever you call me, I'll answer.
So, and perhaps I just need to put in with the epidemiology for a cluster evaluation because, my experience may not be broadly, but in the last year, I've had like 4 firefighters, EMTs with brain tumors, young men, and I didn't see that listed at all. So I'm just a question, is there any association or suggested association between firefighting and brain tumors?
It's a great question. Brain cancer compared to some of the other cancers that we were able to see associations with is a less common cancer. And so when I talked about gaps, I think that is one of the really important gaps is trying to have enough data information to be able to get at these less common cancers. I think it's interesting that there was a study out of Australia looking at the impact of wildfire on population cancers. They saw increases, as you might expect, in lung cancer, but they also saw unexpectedly increases in brain cancer. So I think it is a really important area and one that we're going to be paying closer attention to. Certainly the IARC review and the meta-analysis that we did a part of this did not show an increase with brain cancer. But again, that lack of evidence doesn't mean that there's a lack of association. It may well mean that we just don't have the numbers to see that yet.
If I can chime in on that, because I know one of the individuals you're talking about very closely and talking about modifiable risk factors, I would have put this individual up against anyone in the state of Iowa as probably one of the healthiest, most knowledgeable individuals as far as taking care of himself. And he is still battling, fortunately, he's still alive. He's still battling his brain cancer. But he's been in the fire service, EMS, for 15, 20 years. I can't speak to all the others, but some interesting facts for the state of Iowa. Currently, and this goes to the professional firefighters, 411, which is our pension system for professional firefighters in the state of Iowa. We have 14 cancers that are covered as presumed to have come from the job as a firefighter. There are, as you all are aware, well over 200 cancers out there right now. And there are some states that will recognize the word cancer. If you're a firefighter and you are diagnosed with any cancer, it's presumed on the job. There are some states that have far less than we do in the state of Iowa. So we made a very big push and almost were successful in getting all 200 or just the word cancer included for us coverage in the state. Died in the Senate, and we'll get into that. But we're trying to just change the wording because right now those 14 cancers that the state of Iowa recognizes, and I don't know the exact date, but it's early 2000s. Those were the 14 cancers at the time that were studied and identified to be more of a risk for firefighters. So that's why that random 14 were selected at that time. And now we're trying to make that push internally in the state with our labor unions and everything to have all cancers covered. Because right now in the city of Des Moines, I think we have over a dozen firefighters that are battling some type of cancer. We've lost 2 in the last 6 months to a year to cancer, and we've probably had several more that have retired and diagnosed with cancer as well. So some other statistics as we go through all this that's interesting. She talked about the National Cancer Registry for firefighters. If I retire and I'm diagnosed with cancer, there's zero information going back unless I self-report that I was a firefighter with cancer. I talk about the military, they're always labeled as a veteran. So anything that happens to them, the national government gets that information and collects it and uses it for data. Whereas all these numbers of the higher risk of cancer, as soon as we retire, we kind of drop off those statistics a lot. So unfortunately, I think the numbers around 67% of firefighter line of duty deaths in the last 2 decades have been cancer related. And that's probably very under documented with the idea of volunteers that would never be recognized as firefighters, and those that have retired and died within probably 5 years of retirement from cancer. So it's a huge risk for us. A lot of modifiable things that we can do, and we're working on those things, but at the same time, it's self-discipline to do those as well.
And yeah, I'm really glad you brought up the National Registry for National Firefighter Registry for Cancer, the NFR, because so the way that works, Lieutenant Mark, is that you sign up as a firefighter. It takes about 20 minutes. Current or retired firefighters, volunteer, anyone can do it, and then they keep your information. They then link it to all the 50 plus cancer registries in the U.S. And so that's a population count of cancer. And through that linkage, you're not lost. That is the way we're going to get your information. And that is the way we're going to be able to address these questions about small sample size, about things like brain cancer, things like buoy firefighters. It really is, because they're trying to enroll 200,000 firefighters at least, we'll be able to get at that. And it's so exciting. And I do hope that you can pass the information on to folks in Iowa. I dropped the link in the chat in a minute about how to get on and join, but it's a fantastic effort. I mean, the research efforts are great as well, but this is a U.S. government effort. It's well funded. It's going to keep on going, and it will allow us to get at those at these really big gaps, and your information won't be lost. So that's I'm really glad you brought that up.
Yeah, and I was fortunate enough to be in St. Petersburg, Florida when they rolled that out. So I was one of the first that got to go through that process before it was rolled out. So I am registered, and I've seen a couple of people post about their fathers or mothers, their family members that are volunteers, past retired. Like, we need all of them to register as well to get to that 200,000 number, so that the research is there and can get more funding for more and better research. So it's a good opportunity to help out.
Yeah, definitely. Well, Dr. Graber, Lieutenant Mark, thank you guys so much for your time today. I know I learned so much, and I think we maybe even identified some opportunities for the Iowa Cancer Consortium to better support this work too across the state. So thank you guys so much. We really appreciate your time today.
Thank you.
Thank you. All right, so now I'm going to turn it over to Cindy Feaster. She's also a member of the Iowa Cancer Consortium Board, to introduce our next panel. Take it away, Cindy.
Thank you so much, Sarah. I hope everybody can hear me okay. All right, awesome. I see heads nodding. I have the privilege of introducing our next speaker, Traci Kennedy, who will share about occupational cancer risks for casino workers in Iowa. Traci has been fighting for smoke-free air since she testified at her first city council meeting as a high school student. That is incredible. In her current role as the Midwest States strategist for the American Nonsmokers Rights Foundation, she covers 13 states, including Iowa, at the local and statewide level to protect all employees from secondhand smoke work. She is passionate about the power of coalition building and grassroots policy change to impact population health. Welcome, Traci.
Thank you so much. And I just want confirmation y'all are seeing the slides on your end. Yes? Okay, great. Well, thank you so much for the honor and privilege to be able to speak with you all today. Thanks for the kind introduction, Cindy. I was born and raised in Missouri, and I've been living in Des Moines for the last 6 years, but my work often takes me outside of state lines. So it's really great to be spending time today with fellow Iowans. And I spend a lot of my time talking about secondhand smoke exposure in casinos. So it's an interesting part of our work that for many young people and certain people in the workforce, we are able to take smoke-free environments for granted for the most part. We grew up going to smoke-free schools. We never flew on an airplane with smoke. And so I just have to applaud the Cancer Consortium for paying special attention for gaps in smoke-free protections, because casino workers are the largest hospitality workforce still exposed to secondhand smoke. So I'm going to tell you a little bit about our organization, Americans for Nonsmokers' Rights, as we go along. If you're interested, we can always follow up afterwards, but I really want to talk a little bit about what secondhand smoke exposure looks like in the state of Iowa. So many of you may have been involved in the original passage of the Iowa Smoke-Free Air Act. So we just celebrated 15 years of the Iowa Smoke-Free Air Act. And a significant part of that was preemption repeal. So preemption is when one level of government limits a lower level of government from taking an action that would be in conflict with that higher level of government. So what that looked like in Iowa is that no local community could pass an ordinance or local law that was stronger than the statewide law. The reason that that's important is because most cities in the state of Iowa do not have a local smoke-free law on the books. Many states, that's actually how it works, where you kind of reach a collective mass of local ordinances and then a statewide law passes, but that's not how it went in Iowa. So I would just reiterate that local communities with a casino do have the capacity to pass a local municipal ordinance that would require that casino to be smoke-free. So the original Smoke-Free Air Act did apply to all workplaces, restaurants, and bars to be 100% smoke-free of combustible cigarette tobacco products. That has had a significant health impact, and we're really grateful for the leadership shown at that time to be able to realize the benefits, including cancer risk on lowering cancer incidence in our state. However, significant exemptions do persist, and we see the main ones as cigar and hookah bars, which are two places where you can still smoke, and then use of e-cigarettes. So in 2008, e-cigarettes were just hitting the market, so those are not addressed by the Smoke-Free Air Act. And then, of course, casinos and private clubs. So let's look at what casinos look like in the state of Iowa. So I never thought I'd be this familiar with the gaming industry or casinos, but at Americans for Non-Smokers' Rights, we are a Berkeley-based nonprofit with people out in the field everywhere. And we have made a vested interest in really getting to know the gaming industry. So I was just at a gaming conference last week. We attend the conferences, the trade shows, and we are even shareholders in several casino companies where we are working on resolutions to other shareholders to address the issue of smoke-free air. So the gaming industry has expanded significantly since 2008. Their footprint in the state of Iowa is really almost difficult to wrap your head around. So now we're up to 19 commercial casinos in our state. The American Gaming Association reports it supports 21,000 plus jobs. So that's not just jobs in the facility, but kind of in the general community. We also have 4 tribal properties, which provide an additional 3,300 jobs. The total revenue for commercial gaming, so just those 19 properties, last year was $1.95 billion. Since gaming was legalized in Iowa, I think total revenue, they estimate about $10 billion. And just almost $2 billion of that is in the last year. So that helps you to estimate just how much this has expanded. And the other key component of that is a total tax revenue from tribes and commercial gaming properties of $351 million for 1 year. And why might some of this information be important? I think that when you look at the pervasive nature geographically of this market, what I see when I look at this map, one, I see like my grandparents, their town and where my mom grew up and what it was like when they approved the casino to go into Jefferson, the Wild Rose. But these are also all legislative districts. And each of these companies is contributing both to the community and to the state and to their legislative representation. So what really gets lost on people is employee exposure to secondhand smoke in these venues, because the two things the casino gaming industry touts as their benefit to the state of Iowa is job creation and tax revenue. And based on that slide I just showed you, they're doing a really good job of that. It's just unfortunately that comes at the risk of exposing people to toxic secondhand smoke. So what does the landscape look like nationwide? You know, after 2008, after the Iowa Smoke-Free Air Act passed, we really did see a general slowing of statewide action on smoke-free air. The last statewide law that passed was Ohio in 2012, and that included commercial casinos. But it's been, you know, really about a decade since we've seen significant progress. However, COVID really brought this kind of sea change in the industry and things happening that people said were impossible. So at this point, we have 20 states that require all commercial casinos to be 100% smoke-free by state law. So that means there's 14 states, including Iowa, that still allow smoking in commercial casinos. 150, around 150 tribal properties are smoke-free, either just by simple, that's the casino's policy, or by a decision by the sovereign tribe, their leadership of their tribe. So it's an interesting story, right? One thing you may or may not know about the casino industry is that casinos are always open. Okay. It could be a hurricane or a blizzard, I guess, in Iowa, and they will be open. So during COVID, even with limited restrictions, casinos had to adjust very quickly to be able to operate, which meant being 100% smoke-free indoors. One casino in our state has maintained their smoke-free policy, and that's Prairie Flower. That remains smoke-free till today. So some of those tribal properties, those 150 plus, several of those were passed during COVID that people thought, you know what, actually this worked for us. Workers liked it, patrons liked it. We didn't lose any money. The sky didn't fall. Our facilities are cleaner. We're not dealing with third-hand smoke. We're not going back. So that was an important opportunity for our movement. It's also important to note we're surrounded by very successful smoke-free gaming markets. Illinois has an incredibly successful top revenue generating market that constantly outpaces Iowa. That's also been smoke-free since 2008. Also, I would share Prairie Meadows, if you've heard of Prairie Meadows, is the #1 revenue generator in the state. So that's the top revenue grossing casino in our state, and it's owned and operated by Polk County government. So we leaned really heavily on them. It seemed like a real opportunity to go smoke-free. But there's a heavy investment in the myth perpetuation that smoke-free casinos are not profitable casinos. So, you know, that's a lot of background that I thought perhaps you all, with an inclination to join a cancer consortium, may not know. The background of why I think casino smoking has been maintained, because you all are likely aware of the science and the background that shows us why secondhand smoke in the workplace should not be tolerated and should be addressed immediately. You know, at the end of the day, secondhand smoke that's created from combusted cigarettes or the aerosol from an e-cigarette, what makes these so dangerous is the nature of the particle itself. They're so tiny that it makes them so easily breathed deeply into the lungs. And there's not a ventilation system on the market. There's no other solution other than 100% smoke-free indoor air to eliminate that risk of breathing in fine particulate matter. For those of us public health professionals and nerds on the call, that was another interesting thing about COVID. And outdoor air quality, when we had wildfires last year that were so pervasive and clouding Iowa, a lot more people know what fine particulate matter is now. So we're all kind of talking from the same script. But what gets lost is not only secondhand smoke exposure, but casinos are workplaces. There's a disconnect sometimes with the public and with decision makers that casinos are a destination for fun, for adults, for leisure, but they are workplaces, and the workers we have connected with, they rely on these casinos are open all the time. So there's flexibility to either care for their family, to have additional jobs to make ends meet and cover the cost of childcare, to be there for their families, to coach their teams or whatever that might look like. It provides a living wage with benefits, with a relatively low educational ceiling. So these people like their jobs, and it's not just a job, it's a career. This is a workplace, and this is a career for many casino dealers. So we're really trying to change the script of what that employee experience is like at casinos. And it's extremely well studied. So we are providing these slides, so there's no reason to have to try to dive into this. But this Pennsylvania study was done back in 2012 that really showed the secondhand smoke-induced heart disease and lung cancer for casino workers, an estimated death rate 5 times that of Pennsylvania mining disasters. So for better, for worse, people always like to know how bad is secondhand smoke compared to like a fire or other types of environmental exposure in a workplace. And what we're able to show, unfortunately, is that it is as bad or worse. So the number of toxins, carcinogens, exposure, also concerning unsafe levels of smoke and their pollutants are found throughout the casino gaming area. So even if you have a smoking and non-smoking section, or you only allow it on a percentage of the gaming floor, everyone is being exposed to the harmful levels of secondhand smoke. So a great body of research to show why these policies will work and why they will work immediately. So I think what also is concerning, one of the primary things, not only do casinos create jobs, but they tout that they invest in employing more women and ethnic minorities than any other segment of the hospitality industry. And while that is a worthwhile investment, it shouldn't come at the expense of those same vulnerable populations then being further exposed to secondhand smoke and seeing the related death and disease that come from that exposure. So as a consequence, sort of having your workplace be smoke filled, then during COVID going smoke free and being able to breathe better, fewer headaches. We have casino workers going through cancer treatment who are pregnant. When smoking returned to their workplace, it was just unconscionable. They could not believe they would bring this relic of the past back into the workplace. And it's very reminiscent of flight attendants. Americans for Non-Smokers Rights was founded about 40 years ago, and we worked in lockstep with flight attendants who were getting sick and getting lung cancer and dying from their secondhand smoke exposure on airplanes. And it was it's hard. It really is hard for us to fathom now, but it was nearly impossible to get Congress to act on domestic flights to make them smoke-free indoors. So they decided as a compromise to make smoking sections on airplanes. So some of y'all might remember that, but that to me just seems a ludicrous thought to have smoking sections on an airplane. So the spirit of flight attendants coming together to speak out on this issue is exactly what we're seeing with casino workers across the country. And it really started in Atlantic City, New Jersey, which is the second largest gaming market outside of Las Vegas. These workers for 3 years have been organizing across the country, and their storytelling, their connecting on social media has really led to a nationwide movement where we have casino workers across the country who are now speaking up very clearly about their personal experience with secondhand smoke. And for the first time in a very long time, it's creating action by lawmakers. So we do have a series of videos that I will link with the presentation that I think really capture storytelling. But what we're working to do to get people to join the Iowa Tobacco Prevention Alliance, ensuring casinos are smoke-free is one of our top priorities. We want to be able to connect with casino workers to give them an outlet for advocacy and to share their story about their secondhand smoke exposure. And as always, you can connect with me here at home, here in Iowa, or if you're interested in hearing about any of our other efforts nationwide. Again, I so appreciate the opportunity to come together with you today. I realize I have a candle lit after that very compelling firefighting presentation, so I apologize that I have a candle lit in the background. But it was really great to spend time with you. I think we have a few minutes for question and answer. If any of you have questions about the industry here in Iowa or about our other projects nationwide or casino worker engagement, I'd love to hear them. I think there might be something in the chat, but I was not successfully toggling back and forth. So let me know what your questions are.
Thank you so much, Traci. We do have time for questions here, so type in chat or come off of mute, folks.
I think the one other while y'all are thinking of those pressing questions, after a failure to act in the legislature in the state of New Jersey, the United Auto Workers Union has filed a lawsuit against the state of New Jersey for violating the constitutional rights of employees by exposing them to a known carcinogen. So they have engaged a very high-profile attorney. It's a very compelling case that will actually is already going to trial and will have a decision on May 13th. So that's really significant. Over time, unions have been opposed to smoke-free due to the fear of job loss, but UAW has stepped up to take on this issue nationally and internationally, including from their president, Shawn Fain, to say casino workers shouldn't be exposed to secondhand smoke. So we still hope we still see legislation as the number one path, but we're all following very closely to see what happens with this constitutional challenge in New Jersey.
So Traci, I have a question. If no one else has a question right now, I don't want to interrupt anyone, but I worked for a period of time as a home visiting psych nurse. And at the time, and I don't know if this has changed because I haven't been in that field for a while. At the time, there were no protections for me as a home visiting nurse to have my clients not smoke in my presence. And I can tell you I was constantly sick during my time working in that role. I've never been so sick in my life as during that time. And I'm sure it had everything to do with exposure to that, along with, many other things, just being in homes. But I wondered if there's been any progress in that area in the nation or in Iowa. It's a little different topic. Sorry.
Yeah, it's so interesting you brought that up because, again, this concept of what's a workplace, and there is disagreement in what is a private home and what's a workplace. So in that case, that was your workplace, but is it that person's private home? In that moment where you're there, it's a workplace, but otherwise it's their private home. And this also specifically came up the last two sessions in the Iowa veterans home. So in nursing homes, it's another thing because that is someone's home, but it's also a workplace. So this is actually a little bit of a point of contention when it comes to what the state policy says versus what happens. And largely it gets left up to the individual agency, either like your employer. And I will say there's a lot of progress that's been made in understanding that people shouldn't be like access to nicotine and tobacco products isn't actually an essential part of the treatment process. So in terms of mental health, so there's no need to be able to maintain tobacco and nicotine use to have a successful mental health treatment experience. So I do think we're making progress at the individual based level because it's very hard to recruit and retain a workforce and people don't want to be exposed to secondhand smoke. So it's really, again, it's really been workers advocating to their placement agencies. But this just actually came up in the state of Pennsylvania about foster homes and child care centers. So if you are a foster home providing like respite care, which is like, just every time there's like an emergency or over the weekend, can you smoke in your home when you're not operating as a foster home? So these are kind of complex policy questions that I think make it a lot simpler if we just say, this is why, we have model policy language that really designates what's a workplace, because there are these important questions. And that's such important work that the last thing you want to do is then have to expose people to secondhand smoke in a workplace like that.
Right. Thank you for that. And we do have a question in the Q&A. Georgia is asking us, would the tribal casinos be included in the Smoke-Free Air Act?
Great question. They would not. So tribal casinos are sovereign, so they do not, they are not subject to state law. And that's why it's so important that we have actually seen tribal leaders adapting more quickly and showing better leadership on smoke-free than commercial operators. And the other reason that's important is because for so long, commercial operators used that argument in their favor. They'd say, well, we can't go smoke-free because how are we ever going to compete with our tribal, counterparts who don't have to follow the same rules? But the thing is, sovereign tribes may also have different tax rates in terms of their gaming tax. The entire negotiation structure around the concept of a tribal casino is at its core treated differently than a commercial casino. So this is just one more aspect of the equation. But there is a lot of progress happening. And I think a good example would be Nebraska. So Nebraska just legalized commercial gaming in the last few years. They already have a very strong smoke-free law. So they administered a rule that requires all commercial gaming that opens to be smoke-free. They already have tribal properties that allow smoking, not to mention, if you're thinking like Council Bluffs area, this is the situation where you could be in a casino on the Nebraska side and you could see the other casino on the Iowa side across the river. You could smoke in the one on the Iowa side and not on the Nebraska side. But policymakers and decision makers understand, in this case, the importance of protecting the integrity of their smoke-free law, not exposing people to secondhand smoke. And perhaps they've been moved by the data that shows the number one thing people choose when they're considering where to gamble or to go to a casino. One is driving distance, but two is amenities, like where's the newest, nicest place to go? And then down on the list is even whether or not the casino is smoke-free. And then down on the list is whether or not there's still smoking in the casino. So we just largely don't see that as a decision-making factor for people when they're making their decision where to go. The good news is maybe for workers, perhaps workers on the Iowa side can go get a job on the Nebraska side till Iowa goes smoke-free.
There you go. Yeah. Thank you so much. Do we have any other questions or I don't see any others, I don't think.
I don't see anything, but again, feel free to contact me and thank you all for having me today.
Yeah, thank you so much. And so I'm going to hand this over to Dr. George Weiner, immediate past president on the board of directors for the Iowa Cancer Consortium. Dr. Weiner?
Yes, thank you, Cindy. And I have the privilege of introducing our final speaker for the day, Dr. Frank Cannizzo. So Dr. Cannizzo is the Chief Medical Officer for the Salem Veterans Administration Medical Center in Salem, Virginia. He's a board-certified surgical oncologist and also has expertise in general surgery and clinical informatics. And Dr. Cannizzo serves as a lieutenant colonel in the U.S. Army Reserve and has had multiple deployments to Iraq and Afghanistan, as well as humanitarian missions to Guam, Vietnam, and Cambodia. And so thank you for your service, Dr. Cannizzo, and thank you for joining us. And we look forward to your comments on cancer in the military.
Thank you very much, Dr. Weiner. I first want to thank the Iowa Cancer Consortium for inviting me to talk. This is, as a cancer surgeon and an employee of the VA and an Army officer, this is a subject that hits near and dear to my heart. There are reams and reams of data, statistics, correlations out there. It's been a long day. You've been hit with a lot of stuff. I'm going to take it easy on you and give you more of an overview and a personal perspective on the issue of military toxic exposures and excess cancer risk. Just see if I can share my screen. All right, you should be seeing my slides. Is that correct?
Yes.
Yes, we can see them. Thank you.
Okay. So, like I said, I'm going to be talking about the military toxic exposures and their role in increasing the cancer risk of service members. So if I can get this to work. Yes. So these are my disclosures. Unfortunately, I have no financial disclosures to report. So, I'm just doing this for fun. Although I am a federal employee and the chief of staff at the VA, I'm speaking today as a physician and as a cancer professional only. My comments do not reflect the position or the opinions of the Department of Veterans Affairs, Department of Defense, federal government, or my facility. They are my observations alone. So I'm going to be giving you a little introduction. Then it's story time. I'm going to tell you a story about military toxic exposures and how we got. Hopefully, it'll illuminate how we got to where we are today. We'll look at some of the scope of the problem that we're dealing with veterans in general. Talk about some current issues, and then hopefully wrap up with a slide about the future perspectives. So, what is the excess cancer risk for veterans? Well, it depends. If you look in the scientific literature or you look in the popular press, you're going to get very different impressions of the problem. If you look in the scientific literature, there's a large amount of conflicting data. There have been large studies over extended periods of time on veteran versus non-veteran populations that have found actually lower rates of colorectal, cervical, breast, and lung cancers. On the other hand, veterans who are diagnosed with cancer are about 20% of them. There's about a 20% increase in the diagnosis of rare cancers. And in a study commissioned by the DoD and US Congress last year of Air Force ground crews and flight crews, we found that there were enormous, in some cases, increases in some forms of cancer that are relatively less common in the civilian population. So, I mean, what does this all mean? Are veterans more susceptible to cancer because of their military service or not? Well, it ends up that the news in excess cancer risk in the military revolves more around distributions and clusterings. These are vulnerable populations that are vulnerable because of their time spent in a geographic location or performing a certain job or in the presence of certain environmental factors. So when you start talking about things like a population exposed over time to an environmental factor, and the outcome is excess cancer risk, then you have this kind of Erin Brockovich moment, and you start to look for what's the causative factor, what is the common thread in all of these unusual cancer clusters. Well, let's start with a story. So in 1961, the US government, in the form of the Department of Defense and the Vietnam War planners, decided that it would greatly improve the war effort if we could actually see the enemy in Vietnam. And therefore, if we could remove all the leaves from all the forests under which they were hiding, that would help. There is a strategy to do that. It's by dumping lots and lots of herbicide along egress routes and in forested areas where the opposition was known to hide. So the corollary to that is that when you dump all this herbicide on the landscape, it also kills food crops, which denies your opponent access to foodstuffs that they need to keep going. So it was kind of a two-pronged attack on the opposition in Vietnam. Well, there were a bunch of different agents that were tried. Some of them were more effective, some of them were less effective. They were all color-coded by the tanks that they were shipped in. Agent Orange is the most common and the one that most people have heard of. And of the 20 million gallons of herbicide that were dumped on Vietnam between 1961 and 1971, 13 million of those gallons was Agent Orange. There were 6,500 or more missions to deliver herbicide to the landscape. About almost a quarter of the land area of Vietnam was sprayed, and the exposure is estimated at about 2.6 million US service members and 4.8 million Vietnamese. So what is Agent Orange? We've all heard the term. Some of us know more about it or less about it. It's actually a combination of two commercially available herbicides that were used extensively in the United States in agriculture and industry. Both of the components, the attractiveness of using these commercially available components is that we had a long experience with them, and they break down within a couple of weeks and remove themselves from the environment. So they were thought to be perfect weapons against the forest canopy. The Department of Defense, in order to acquire sufficient quantities of these herbicides, pressed 3 of the chemical manufacturers in the United States into vastly increasing their production capacity. And that's going to become important in a minute. So after this Operation Ranch Hand, as it was called, where the US government or the DoD deforested large parts of Vietnam using various herbicides, Vietnam vets started to come home and check into the VA. And after a couple of years, we started to see clusters and groupings of unusual symptoms. So skin rashes, immune dysfunctions, weird neurologic and hormonal disorders that were more prevalent in the Vietnam veteran population. In addition to that, cancer clusters of bladder and prostate cancer were occurring in veterans younger than the civilian distribution of those cancers. Hodgkin's lymphoma was being seen in older patients, and the chronic B-cell leukemias and the non-Hodgkin's lymphoma were being seen in numbers that exceeded what you would expect of a civilian population. Soft tissue sarcomas rounded out that menu of cancer diagnoses with these, fairly rare cancers. Sarcomas generally make up about 1% of all diagnosed cancers, excluding skin cancer. And in the Agent Orange population, it can make up to 16%. So lacking a clear correlation with military exposure, the VA denied all of these claims from veterans who stepped forward who were exposed to Agent Orange or purportedly exposed to Agent Orange during their overseas tour, and came back with unexplained symptoms. So the lack of a true correlation, the lack of a firm correlation in the scientific literature was leaned on by the VA, despite the fact that there were several large studies in the 60s using these agents to determine that they were teratogenic and that they induced birth defects and could induce genetic rearrangements or genetic damage. And also, the VA is a different federal institution, but the EPA actually prohibited the Department of Defense from bringing any of the herbicides that were left over from Operation Ranch Hand back into the country to be destroyed. They had to be shipped to the Johnson Atoll in the Pacific Ocean to be destroyed. So there was certainly a suspicion that this was a toxic mixture and could be hazardous to human contact, but lacking an obvious or provable connection with these symptom clusters, they were still not being covered by the VA. Well, the tide turned in 1977 with the death of specialist Clive Owen, who died of an unclear cancer diagnosis, and his wife approached the VA for survivor benefits and was denied. A Veterans Benefits Authority worker in the Chicago office by the name of Maud DeVictor became interested in her claim because of the frequency with which claims similar to it were being brought to their office. She took it on herself to look into related claims and began to collect these claims and correlate them with the symptom complexes and the cancer diagnoses that were being experienced by returning Vietnam veterans. Once she had gotten a mass of these cases, she brought them to an Air Force biologist down at Eglin Air Force Base in Florida named Major Alan Young, who became very interested in cancer clusters around Vietnam veterans who worked with or worked in areas where these herbicides were used. So right about now, since this is a multi-agency kind of inquiry, the VA began to question Ms. DeVictor's use of time and asked her to stop. Well, that request fell on deaf ears, and by the 80s, Ms. DeVictor and Major Young had a mass of correlation that was really too much to ignore. The information leaked out to outside sources. It was picked up by the media. It was the subject of a PBS documentary, a couple of books, and several ongoing research studies through the NIH and NCI, to the point where the mass of correlation data was such that in 1991, President Bush signed the Agent Orange Act, mandating that the VA provide benefits for Agent Orange exposed veterans with a relatively smaller set of presumptive diagnoses, but certainly those veterans were eligible for all of the benefits required to take care of their health and their disabilities. So during this period of time where there was active research into why two relatively non-toxic herbicides should cause this kind of health effects on exposed veterans overseas, some answers started to emerge. Turns out that the herbicides that were used in Agent Orange and most of the other color-coded agents were relatively non-toxic in and of themselves. However, the manufacture of these herbicides was known for a long time to generate the extremely toxic byproduct dioxin, or TDCC. So dioxin was known to be a contaminant in the production process, and it was factored into the safety profile of the commercially available herbicides. Problem is, when the DoD leaned on those three chemical manufacturers and ramped up their production by tenfold and sometimes more, the quantity of the contaminant increased disproportionately. Turns out that the herbicides we were shipping to be used in the Vietnamese theater were far more contaminated with dioxin than the commercial products ever were. And dioxin, for those of you who don't know, is a forever chemical. whereas the herbicides last a couple of weeks, break down, and are washed out of the environment. Dioxin can last 20 years on the surface of the soil, up to 50 or 75 years if it's buried 6 or 7 inches below the surface. There are areas in Vietnam where dioxin is still leaching out of the soil after rainfalls, after the monsoon season. So the guilty party here is not so much the herbicide, but the contaminant dioxin, which has been known for many years to be causative in a number of human illnesses and a number of cancers. So is this a new thing? Is this an isolated incident? No, of course not. Every war has had its toxic exposure and its effect on returning veterans, surviving veterans. World War I had nitrogen mustard gas, which, in addition to the respiratory effects that survivors suffered for years and often for the rest of their lives, was a contributing factor to oral, laryngeal, lung, and skin cancers. World War II, in the shipyards, we all know about the asbestosis issue and its association with mesothelioma. In researching this talk, I found, much to my surprise, that there have been numerous reports of both American and British officers succumbing to radon-induced lung cancer as a result of their use of radium painted watches and compasses during their time overseas. Some of these watches that were given out to British officers emitted 20 times the toxic dose of radon when kept in an enclosed room. In Korea, the volatile chemicals that came from cleaning supplies and paints was indicted in the increase in oropharyngeal cancers that we see in that veteran population. In Vietnam, you already know about the Agent Orange effect, but it's not just in war that we expose service members to potentially harmful toxic chemicals. Many peacetime areas have their risk too. I don't know if anybody's heard of Fort Ord, California. It was an ordnance base throughout most of the 60s, 70s, 80s, and even the 90s. It was closed in the early 2000s after being found to be the most contaminated military installation in the United States. There are still efforts ongoing on that closed base to catalog some of the contaminants that have yet to be definitively identified. The multiple myeloma rate among former residents in some subpopulations has reached almost 35%. So it's an incredibly increased excess cancer risk just from being around some of those contaminants at the levels that are present on Fort Ord. Most people have heard the name Camp Lejeune. Camp Lejeune, North Carolina, was a Marine training base. In the early 80s, late 70s, early 80s, the water table there was found to be contaminated with volatile chemicals, jet fuel and cleaners and other volatile chemicals that rendered the drinking water virtually unusable. Unfortunately, many Marines and their families have passed through Camp Lejeune over the years, and it's been implicated in elevated risks of all of these cancers, mostly lung, breast, and upper aerodigestive tract diseases, along with some of the endocrine cancers and, again, soft tissue sarcomas. And this litany of toxic contamination goes on and on. Recent studies by the EPA demonstrated that at least 63 military bases in the United States, over 29 states, have drinking water that's contaminated with PFAS. PFAS, as our previous presenters from the firefighting community would let you know, is the chemical used in making aqueous film forming foam, which is implicated in elevated testicular cancer risk in male firefighters, ovarian and breast cancer risk in female firefighters. Well, that's what's contaminating much of the water table in many of those bases, because PFAS containing aqueous film forming foam was used on all bases that had air assets, because jet fuel burns fast and it burns hot, and it's aqueous film forming foam for many years was the only thing that could reliably control those fires. So did we learn from all of this? Well, yeah, we have. And the toxic exposure that current service members can expect to encounter is far less than it was in the past, but it's still not perfect. And for every toxic exposure, for every predictable toxic exposure that's eliminated from the lives of service members, another one seems to crop up. Over the 20 years of our presence in Iraq and Afghanistan, and before that, for a couple of years in Kuwait, we burned all of our garbage. We burned all of our garbage. We burned our intelligence documents. We burned our leftover equipment, and we burned, equipment and uniforms taken from enemy combatants. Well, we generated a burn pit toxic exposure to which we don't even have a real estimate of how many people were encountered that kind of exposure. And now we are seeing burn pit exposed veterans come back with a whole host of cancers that are unusual for their demographic characteristics. Brain and CNS, I know we've talked about that over the course of some of the other talks. Kidney, pancreas, hematological cancers that are unusual for this population. But again, our ability to remove toxic exposures from the military landscape gets better, not perfect, but better. Our response to the ones that are left over is getting better. In 2022, the PACT Act was passed. It's the Sergeant First Class Heath Robinson honoring our promise to address comprehensive toxics act. Sergeant First Class Heath Robinson was a young man who served in Iraq, and over the course of several deployments came home with a metastatic lung cancer from which he ultimately succumbed. His wife has become an advocate for support for our burn pit exposed veterans, and she's become a very effective voice along with many, many others. PACT Act is a direct consequence of their bringing this subject to the fore and having Congress and the DoD listen. It's the largest expansion of VA benefits for veterans from all time periods, from Korea through Vietnam, through the interwar period, Cold War, through the Gulf, Iraq, and Afghanistan, and recognizing a wide range of presumptive diagnoses, including a fairly comprehensive list of cancers. So, in the end of the day, military service is a risk factor for cancer. And the reason is because the military is always going to be a hazardous profession. Being in the military means handling or being close to people who handle stuff that, I don't know, blows up, pierces through you, rolls over, or otherwise, is built to hurt people. We ride in conveyances that either can fall out of the sky, sink under the water, or just sort of catch fire. It's a dangerous profession, but exposure to toxic material, exposure to toxic environments is almost always avoidable. It's almost always preventable. With proper selection of chemicals, proper use of protective gear, and proper precautions for where and when those chemicals are used, the exposure to individual service members can be absolutely minimized. Early recognition of things that might be hazardous that we may not know everything about when they're put into service, early deployment of mitigation practices and practices to limit exposure are all keys to keeping people safe. In the end, we owe it to people to do better. And from what I've observed, we are, but we still have a long way to go. I'd like to take any questions.
Dr. Cannizzo, thank you so much for a great presentation. And we have a few minutes, so maybe I'll kick it off. You talk mostly about rarer cancers, but are there any specific recommendations concerning cancer screening for veterans who we know have had these exposures? Is there anything in the community we can be doing to try to catch these cancers early?
Yeah, there are. Our veteran population undergoes very stringent GI, lung, and prostate cancer screenings. We, as an agency, the VA has embraced low-dose lung CT as a screening modality for moderate and high-risk populations. We have for a long time relied on PSA and free PSA as our markers for prostatic malignancies, but we're rapidly moving into genetic testing of prostatic tissue and liquid biopsies as a way to detect early detection. We have talked about, but haven't yet enacted expanded age ranges for various cancer screening programs, but that is a subject of ongoing conversation.
Thank you. Any other questions?
I'll jump in. Thank you so much for the presentation, Dr. Cannizzo. That was absolutely amazing. So as a military brat, I do want to ask about dependence. So as you were talking about some of the bases in the US that are contaminated or have like water systems that are contaminated, is there any talk about exposures and what might be appearing in dependence? Do you know if there's research going on, or is that kind of separate since the VA is for veterans?
Unfortunately, the VA is enjoined legislatively from treating dependents. We just can't do it. It's not in our charter, and we're limited in the amount of care we can give to non-veterans. But there are absolutely congressional avenues by which veterans beneficiaries and their families are receiving care. The Camp Lejeune situation is a little bit different because that kind of started, as you remember, I said it was the 70s and 80s. This has been ongoing for many years, well before kind of we started to be more proactive. And the beneficiaries and families in that group are being managed through a lawsuit, a class action lawsuit. I knew there was a word for that. But again, there are legislative avenues for providing care for non-veterans who were exposed to these kinds of toxins as a result of their association with the Department of Defense. I hope that answers the question.
Yes. So thank you again for a fantastic presentation and for your service. And I think we're right on time, Kelly, so I can turn it back over to you.
All right, thank you. Thanks, Dr. Weiner, and thank you to all of our amazing speakers today. I have a feeling that you'll be fielding some questions via email. We just are so grateful for your time and for all the work you're doing. Obviously, the places we work are very important environments in our lives. And so the consortium staff wants to make sure that everybody here knows that if you're interested in what you heard today and you would like to sign up to receive emails from our Cancer and the Environment Task Force, you can email Caroline Powell, and her email address will be in the chat. We also hope that you'll take time to complete the evaluation for today's meeting. The URL will also be in the chat and will be emailed to you this week. This really helps us as we plan future events. And please note that the evaluation that you'll receive via email is separate from the required evaluation for CEUs. If you are claiming CEUs, please be sure to follow the instructions that were shared at the beginning and via email and in the chat. The link will be in the chat one more time. Be sure to take that first step within 24 hours if you'd like to get your CEUs. And then finally, thanks to all of you for attending today. Just always excited to have an opportunity to get the network together. Thanks for your thoughts and your feedback and just spending 3 hours all together today. Hope you all have an amazing afternoon. Mark your calendars for October 15th for the Iowa Cancer Summit, and we will see you very soon. Thanks, everybody.